the initial slides covered.
We'll be starting shortly. Just please give us a couple of more minutes for all the participants to get on the webinar, and we'll be starting in a minute or so.
Good morning and good afternoon to all the participants in this UICC webinar on prognosis and prediction. My name is Mary Gospodarowicz, and I'd like to welcome you all and thank those of you who have participated in our work, completed surveys, volunteered your talents to help us collect the data on prognosis and prognostic factors in cancer. Let me just share my screen. I think, Susanna, can you show my slides? What do I do? But can I move my slides? No, you have to move my slides. Yeah. Okay, so today we're going to talk briefly about different concepts, definitions, and opinions on prognostic factors and on outcomes that are important when you consider cancer control. And we will consider cancer control in many parts of the world. Can I have the next slide? The objective is to discuss factors affecting outcomes in cancer and also consider the factors that are important in clinical work for decision-making, for evaluation of quality of treatment, for communication with patients, and for research. We will talk both about prognosis or prediction, and in the part one of the webinar, we're going to talk about cancer registries practice and stakeholders' needs who are involved in cancer control. But in part two, we're going to talk more about the importance of data in cancer control and role of prediction in decision-making. And we have very interesting visiting speakers to us who hopefully will stimulate discussion and stimulate our thinking about the role of prognosis and prediction in decision-making in cancer care. Next slide. So the assumption that we've made is that prognosis in cancer implies a calculated probability of an outcome. It's scientifically determined, and that the factors that can influence clinical outcomes can be divided in three main groups: that of tumor profile, whether it's a a histopathological molecular tumor characteristic, or whether it's extent of disease, into patient's characteristic, which is everything that the patient would have if they didn't have cancer, the age, the race, their comorbidities, and so on. And the third huge group, which we called social determinants and environment of care, which looks at any factors that can affect the outcomes that are outside the patients and independent of the disease and patient's characteristics. One thing to remind you, and it's going to be emphasized again, that prognosis is always must be considered in the context of an intervention. And lack of intervention, lack of treatment is also an intervention. And the prognosis should also be always be talked in the context of specific outcome, whether it's overall survival, whether it's disease control, whether it's preservation or function, and so on. Most of us who are involved in this seminar are part of the UICC TNM and Prognostic Factors project. And that project publishes the TNM cancer staging classification, is also involved in classification and publications about prognostic factors in cancer. And in 2019, now almost 4 years ago, we were challenged by Sherban Negota from US NCI, who said, so you're working on staging prognostic factors, and what factors and outcomes should be recorded by population-based cancer registries if the endpoint of the exercise is improved global cancer control? So it was a very challenging assignment, and we convened the group to work on that. Next slide. And in today's webinar, in part one, we're going to report on the specific parts of the project that we executed. The project is still being worked on. We haven't quite finished our activities. So today we will give you the results of the expert interviews that we have conducted. And actually Jim Briley will speak for Meredith Giuliani on that. We will talk about a cancer registry survey, and Elizabeth Van Aken will present that, and talk about stakeholders' needs based on the survey of 9 stakeholders groups. And we'll also mention the project that we just started, which is select diseases, specific multidisciplinary focus groups, and Brian O'Sullivan will discuss that. We'll present the preliminary analysis. The analysis is ongoing, and we will summarize it at the end of the project and come up with recommendations. Next slide. But today, so that's what we're going to do today. We're going to present the results. We're going to have panel discussion. We're going to solicit your input and feedback and suggestions for additional data analysis. Please place your comments in the chat, place your questions in the Q&A sections for us to be able to respond. Next slide. And in part two today, after a short break, we will discuss the progress in cancer registration globally. And we're very lucky to have Marion Pineros from IARC to talk about the GICR project. We will also explore the needs, challenges, and opportunities for data supply for cancer control. And we have Professor David Jaffrey from MD Anderson Cancer Center speaking. And we're also very lucky to have Avi Goldfarb, professor in Rothman School of Management in Toronto, to talk about prediction and decision based on prediction. Their presentations will be followed by panel discussion on all these subjects that will be led by Dr. Jaffrey. Next slide. So disclaimers, these are preliminary results. We're continuing to analyze it. Disease-specific focus groups will continue. We welcome your input. And we also want to emphasize that our work relies on volunteers. All the study teams are volunteers. We've had hundreds of volunteers completing surveys and also people volunteering for focus groups. They come from all over the world, and without their participation, we wouldn't be able to complete this project. So again, please put comments, questions in the chat. Next. And I'd just like to acknowledge all the investigators, collaborators, and specifically, I'd like to acknowledge Eleni Giannopoulos, who sent out all the surveys, keeps us on the project and has also completed all the analysis. And special thanks to Susanna Tittenbrum from the UICC, who organizes us and keeps us on straight and narrow, and to Shonali Johnson from UICC, Sherman Negoita and Lynn Permbety from NCI for stimulating this work and discussion. And I think next slide just says thank you, right? So over to Jim Briley to give the next talk and also moderate the part one.
So thank you, Mary. I'm Jim Briley. I, with Mary, co-chair the UICC TNM Prognostic Factors project, and I will be presenting an introduction to that's not on the slide, there we are, that better. So some of this overlaps with what Mary has said, but it's a little bit more detailed as an introduction to the whole idea about prognostic factors and clinical outcomes. I would like to acknowledge everybody who is part of the project steering group, myself and Mary Gospodarich, Meredith Giuliani, Brian O'Sullivan, Brian Roos, Elizabeth Van Eycken, Sonali Johnson, and Susanna Tittenbrun, who's the project officer, and our research associates, initially Michelle Broadhurst, but as you've heard more recently and in more length of time, Elena Giannopoulos. Prognostic factors can be defined as variables that can be used to estimate the chance of recovery from disease or the chance of disease relapse. Numerous factors are known to influence outcomes: the tumor profile, the type of tumor, its molecular characteristics, for instance, the anatomical extent of disease, patient's characteristics, age, gender, but their comorbidities, the type of treatment or any intervention that they have, and also social determinants of health, including the environment of treatment. Prognostic factors have an important application in cancer control, including patient care, research, and cancer control programs. For a long time, the UICC have promoted the idea of this prognostic factors grid, which is divided into three types of tumors, of prognostic factors: essential ones, which are needed for clinical guidelines; additional factors which may not be part of clinical guidelines, but physicians often take into consideration when determining treatment; and new and promising factors. And these can also be then divided into those that are tumor-related, such as the histological type and extent of disease for essential, and other essential things are host-related, such as the age of the host and the performance status, but also environment related or social determinants of health, access to treatment, for instance, and the quality of the treatment given. So all these prognostic factors are important, but can be thought of in this form of classification. The other important thing is to think about is what prognostic factors are you looking at and for what outcome. We know the prognostic factors can be different depending on the patient's situation. So the prognostic factors at the initial treatment may be different than compared to when your patient has recurred and relapsed. Then the prognostic factors may be different in that situation. That does depend on the scenario of the situation being looked at. So when we come to outcomes, there are multiple different outcomes that we're interested in. The usual is survival, and that can be crude survival or disease-specific survival, and also progression-free survival. We also, outcome can be the response of the tumor, is it decreased in size, and the time to an event, such as the progression-free survival, the time to develop a metastases, for instance, but also toxicity and the side effects associated with the treatment. The other things that are important can be patient-reported outcome measures and patient-reported experience measures. And finally, the other things to think about are social outcomes, return to work, for instance, and productivity. So at a population level, an understanding of prognosis can contribute to the identification of individuals at a greater risk of cancer and therefore support preventative efforts, but also monitoring the results can help with cancer control interventions. And so these factors, prognostic factors and outcomes, should be ideally collected by cancer registries to enhance cancer control and promote appropriate care. So the UICC TNM Prognostic Factors Project held a consensus meeting involving key organizations involved in cancer prognosis and cancer registries, and it emphasized the value of prognosis in cancer, factors affecting prognosis, and the importance of outcomes. It concluded, however, there needed to be a consensus was required to understand and support the challenges of prognosis, the efforts to standardize recording and effects of outcome, and consistency between outcomes. And this led to, as Mary Gosbrouch saying, the challenge from the NCI and the development of a proposal to look into the concepts, definitions, and recommendations for prognostic factors and clinical outcomes of cancer control. This was developed and the proposal submitted to NCI end of 2019, and then just before COVID, and then COVID had a deleterious effect on both our planning and our proposals. So things have taken longer than we expected. And it resulted in challenges to the structure and timetables and our deliverables. But as Mary says, we've got things to show now, and we're going to be presenting that. The first part of the proposal was to have a workshop, which we did in 2020, when we thought that COVID was coming to an end, but we were sorely wrong about that. But the consensus was that prognostic factors requires an inconsistency in approach and standardization. We do already have well-defined frameworks for classification of prognostic factors. There's the AJCC, for instance, in certain diseases include prognostic factors with an anatomical extended disease to develop their prognostic stage group. And there's the UICC grid that I showed you earlier. When we look at cancer registries at the population level, prognostic factors can be collected and studied through cancer registries. And the national and regional cancer registries across the world are heterogeneous with respect to data points that are collected and their level of sophistication. One of the first things we did was perform an environmental scan of population-based cancer registries in North America, Europe, and Australia. And I thank Elizabeth Van Eycken, Betsy Kohler, Jim Offenberg, and Joanne Aitken to help with this. There's a large variation in what prognostic factors are currently being collected by various cancer registries across the world. The environmental scan highlighted key feasibility challenges in data collection with access to data and time to collect data is a problem, and also data governance can be an issue. But there was a consensus that there's a need for standardization across cancer registration and research. The type of disease and cancer stage are conventionally the minimal data collected by population cancer registries, but these fields can be enhanced by collecting additional data that reflects prognosis outcomes so that strengthen the evidence and need to support appropriate use of scarce health funds. Data must be leveraged to demonstrate improvement in prognosis and outcomes. And it's crucial to support global cancer control activities, deliver healthcare services at lower costs, and offer better quality and improvement in patient experience and in health system. So after that first meeting and the development of the environmental scan, we went on to further aspects of the project. These are structured interviews which have been performed. And as Mary said, the surveys of both registries and stakeholders and stakeholder focus groups, which will be presenting shortly. That's the completion of my introductory presentation. Unfortunately, Meredith Giuliani, who is unavailable today to present the findings of the structured interviews. So I am going to present this. So this is the, other than the environmental scan of registries, this was the next step in the project. The background I've gone over really before, so I'm not going to repeat that. This was a structured interview of 10 people. There's a one-on-one semi-structured telephone interviews. They occurred between June to September 2020, and they range from 30 to 60 minutes. Those being interviewed were all involved in cancer control. We discussed with them the current collection of prognostic factors and the barriers to collection, and how outcomes were being collected, and again, the barriers to collection of outcomes, and how this data was being used, and how to move forward. There were 10 individuals, all who worked in cancer registries or were experts in global cancer control, who were invited to these semi-structured interviews. 80% were male and 80% worked in high to middle income countries. Various backgrounds, some were clinicians, some had non-clinical backgrounds, included statisticians and scientists as well as clinicians, mostly located in North America and Europe. They all agreed that the most important thing to collect, so when it came to prognostic factors, was the anatomical extent of disease. But the future collection included important to collect recurrence, patient-reported outcome measures, and quality of life. When it came to the challenges, the really main challenges was limited coordination among databases, not just cancer registries, but other databases. Getting access to data, variability in data coding and reporting and then definitions in data coding, and also conceptualization and prioritization of meaningful prognostic factors and outcomes. And the biggest challenge was infrastructure and funding challenges, which sort of overlapped with all these other aspects. So when it came to future priorities, the main things was need for global investment and intention in cancer surveillance to help collect prognostic factors, outcomes to facilitate policies and public health initiatives and treatment decision-making. And there needed to be leadership and championship of this as well. And also the problems with regarding to data governance and access to data and technology to help this collection and harmonization of definitions and classification. These are some quotes, but I won't go over them into any detail, but we have actually written this up as a paper, and it has been published, and we can provide a link for that. So on behalf of Meredith, who led this project, thank you. So are there any questions or things that we need?
We can do them in
We'll do that in
the panel.
Okay. So in that case, I will hand over to Elizabeth Van Eycken, who led the registries project.
Thank you very much, Jim. And we already had some reflections on what is needed. And let's have a look together. It is my pleasure to introduce the first results from our Global Cancer Registry survey today in this webinar. And as the screen is appearing, hopefully for all of you in a moment, I would like to give you an overview on, yes, you can go to the Cancer Registry survey, our working group and collaboration, because you know we can do a lot alone, but together we move further. Let's look at the scope and the purpose of the survey. Let's check the methodology. And of course, you're waiting for the results and a conclusion that we want to set up. But especially we want to give the voice here today to the cancer registries. Yes, next. Perfect. This work is the result of our working group. The working group, you see the names represented from different parts of the world, collaborating with IARC, the Global Initiative on Cancer, the African Cancer Registry Network, North American Association of Central Cancer Registries. We are really grateful for every input and effort you have given. And we want to send a special thank you to all the cancer registries that have taken the time to participate and also to test the survey. Of course, the flowers are especially also for you, but next you will see all the logos of the participating and the collaborating organizations, and everybody is always proud to see his logo appearing on that. So I want to thank many persons personally, of course, but here you see the logos of the organizations they are representing. Scope and the purpose of the survey, we wanted to explore the activities of the registries across the world. But especially we want to demonstrate the use of and the benefits from having these population-based cancer registries. So first question is what is collected? And of course that work is already done many times by IARC and all the other cancer registration organizations. But we had to couple that, of course, with some answers, why we asked the cancer registries again to answer on that. What is it used for, the data? Is it only for reporting purposes or locally for planning, or is it also for policy reasons? And who is using the data? We also want to learn more about the challenges, the opportunities, and of course, the perspectives of the different cancer registries. As you can see, we invited 269 cancer registries represented all over the world, and we had a good response of 141 or 52% of the cancer registries, which we consider as a good response. And we are grateful for the willingness of the cancer registries, of course, to have participated. The distribution at the right over the World Bank regions seems very reasonable, with a small overrepresentation of European cancer registries. We had 7 sections of the survey, and we will zoom in and highlight the 4 sections that are at the bottom of the list. About legislation, of course, data protection, funding together, access and analysis and use of data, the future plans and barriers, and together that is taken into account is the recommendation and the comment of the cancer registry. As you can see on your left, the survey was filled in mostly by the director of the registry for 60%, followed by data managers, statisticians, and researchers. The figures in the middle show that we have a good distribution of the population size for the cancer registries they cover, going from a minimum of about 100,000 to, of course, more than 10 million for some registries. And the start of the registry ranged from the middle of the 20th century, which is already there for decades, and until very recently started cancer registries. So we cover a bit the full picture. And of course, we wanted to know, yes, please. Of course, we wanted to know if the cancer registries have their data published in cancer incidence in 5 continents. And with the exceptions of North America and Central Asia, we have for all regions cancer registries that have or don't have their data published in cancer incidence in 5 continents, which also gives a very broad look on the cancer registries that exist. Sub-Saharan Africa and South Asia are represented with some more cancer registries that are not yet publishing the data in cancer incidence in 5 continents, but we all know that they are working very hard to do so. The information collected by the registries is quite what we expected, and the usual variables as incidence date, basis of diagnosis, topography, and the classification of the tumors, because Professor Einkri always asked also to focus on that it's a multidisciplinary task to good classify the tumor, and which is, of course, one of the main subjects of a cancer registry and where we train our data managers for. Less registries are collecting data on the nature of initial treatment, on the nature, which means that this is a very basic level of having an idea on which treatment modalities have been used. So you can see that there is still work to go on if we want to be part of cancer control mechanisms. Yes, please. What information is collected? You can see here, and you can discover that the following information on socioeconomic parameters, ethnic group, comorbidities, is never collected in half of the reporting cancer registries. And these are, as you have seen from previous presentations, also when we want to look at the variation and of the distribution, we have to have better insights in the representation of the different population groups, for example. Yes. The response to the question if stage or extent of disease, because we are here at UICC TRM Core Committee also, and you will forgive me that we will go a bit into detail on stage, is collected was very positive. 86% of the cancer registries, they responded that they are collecting for all or for some selected tumors. If we would have done this survey 20 years ago, the picture would have been completely different. Let's mark also that 50% of the cancer registries started already before 2001 collecting information on stage, extent of disease, and 50% started after 2001. The systems used for stage and extent of disease in the World Bank regions, they really differ. In Europe, there is a dominant use of the TNM classification, followed by a more condensed version of TNM. North America indicates to use SEER, summary stage, and all the others have a mixture of systems. In Sub-Saharan Africa, essential TNM is mostly used. The registries are mentioning that they are, of course, collecting the information, but what can you do with the information? And here you can see clearly that the percentage of stage information availability varies over the different tumor types and over the different cancer registries. It is best for breast and cervix, and you have to note that for many registries, they only cover stage for less than 20% of the tumors they are collecting data for. So I think this is normal then that publication and reporting on this information is not done because of the risk, of course, of huge biases. Next, please. Let's move to outcome measures with the prognostic factors also in the back of our head. Survival and the possibility, it's at the bottom of your figure. Survival and the possibility to follow up on multiple tumors, so the second and even third and fourth primaries, are outcome measures that are available in more than 85% of the responding cancer registries. And you see that this proportion immediately drops for, if we talk about recurrence as an outcome, postoperative mortality, and the patient-reported outcome measures, where the majority responds that they never have these outcomes. This is rather the same for all the World Bank regions when considering survival and reporting on multiple tumors. Yes, please. When it comes to patient-reported outcomes, note that if the answer was positive, yes, we are reporting on that, or we have these data available, then it is only mentioned as sometimes. This is probably related to the fact that it is within specific and ad hoc projects that are done. Next, please. The next outcome measure is on recurrence, and we all know that this is in the cancer registry world, and I think everywhere, a kind of challenge to think about that and even to work on efforts to include recurrence data in a cancer registry. We all know that it's not easy to do so, and the different regions are, as you can see, differently tackling that. And you can see that Europe, East Asia, Latin America, all are interested and are even always doing that, while others are saying in half of the cases that they are never collecting data on recurrence. Another thing maybe on relevance, and also if we want to be considered in the global access to cancer control, 1/3 of the cancer registries, they publish the data within 1 to 2 years after the end of the incidence year. And another good third does this within 3 to 5 years. And of course, 3 to 5 years is late. When you're speaking to clinicians, they will also tell you that it is too late. Is this still relevant? So I think we have to move up to another level and try to be a bit more early in reporting the data. And this is a struggle for all the cancer registries. So this is not related to one of the regions. This is a problem of all cancer registries, and that was well reported. Let's move now a bit to the legislation, and it's in 3 parts. 2 in 3 registries, they report that they have a specific legislation on cancer registration. And this seems to be less the case for Sub-Saharan Africa and South Asian registries when compared to other regions. The second part is the question if cancer is a reportable disease. And there is also variation in answers between the regions for this question. For the majority, there is a law or a kind of administrative order to report on cancer. But you see that everywhere there is also a no answer to this question. And the third is there a law on personal data protection? In Europe, this is completely covered and all registries are responding yes. And indeed, there is a European law, but for the huge majority, with some exceptions in 3 regions, you see that there is no law on data protection. Registries are funded, of course. Registries, they could tick here more options, and indeed 33 of the registries, they selected more than one response. But I think that there is no discussion, and the funds for the large majority of cancer registries comes from the government authorities, followed by research grants, cancer societies, and hospitals. You see, never from industry, only 2 from health insurances. What kind of reports are published by the cancer registries? Almost all cancer registries, they mention to publish cancer incidence reports, directly followed by reports on survival, but also special issues on subjects like geographic distribution, on more age-related aspects, childhood, adolescents, young adults, or cancer in the elderly, on specific cancer types. Risk factors, associated cancers, and quality of the data, of course, but also clinical audits came up in the answers. The question about who asks for this information and who could obtain access to the data, which is different because you can ask for information and for tables, can be different from who wants really to access the data and perform research, for example, but it was answered in completely the same way. So those who are asking for information are also those that are asking for like to have data access. Most of these questions come also from the government, clinicians and researchers. But please note here that also the press, general public, industry, patient advocacy organizations do need the information of the cancer registries. This also means that we have a broad stakeholders public to be taken into account. How are the materials used? Note that we have an important part of missing data here, or that it is not known, not filled in. But most of the materials of the cancer registries are used in the context of outcome measures, policy planning, student and general public information. Clinical practice review is mentioned by 69 registries. So that means that the approach and the gap sometimes between registration and the clinicians is lowering, of course. Only a small part of the cancer registries report that data are used for market access studies, of course, on the question of the industry. And let's move to the fact, do cancer registries, do they plan to expand the activities in the next 2-3 years? And only half of the registry says, yes, we want to expand our activities in the next 3 years. And it is more pronounced in sub-Saharan Africa. Probably they want to move on also and maybe have more cancer registries and try to put them in more centralized registration. Which activities to be expanded in the next 2 to 3 years? 12 cancer registries, they marked that they would merge, they would like to merge cancer registries into one central cancer registry. And 23 of them reported to want to expand the population that they cover. And you see that it's for all the regions a bit different. Please. Which activities should be expanded in the next 2-3 years when we are considering more quality and technical procedures? Let's start at the bottom, which is the lowest one, extend the inclusion criteria for the cancer registry and start to collect data on stage. And this is, for example, this number of registries mentioning this is lower than the registries that are marking that they are not including stage in their registration. Of course, a lot of the registries, and this is a quite similar number, want to expand the number of variables or information and sources for the registry. They also want to have more techniques to be implemented to improve the quality and the validity of the data and trying to capture data with newer techniques and change methodology also to optimize the time between cancer diagnosis and reporting cancer incidents. So I think that cancer registries are also aware of the problems and the issues they face and want to do something about it. Yes, please. What are the barriers to realize these plans? And I think there's a rather homogeneous view, and also the registries could take more of the answers, of course. And the two main issues coming back in most of the cases are, as you expected, because this is no surprise. If we would ask other organizations, that would probably be one of the main things too, are funding and human resources. Data protection is mentioned, lack of access to information, being able to, or having the authority or having the permission to have the information. And they need collaboration. They are reported all in the same way. When taking into account that new techniques are available to facilitate capture of data, it seems important that almost half are also mentioning the missing structured information in the medical files, which is a lot. Please. When reporting on funding, 3 issues came up. Expected reduction in funding, lack, and remember the question about growth, we want to expand, lack of stability in funding, and lack of growth in funding. And lack of stability was a major issue for Latin America and sub-Saharan Africa. For all the registries, also when we look at the other side in human resources, one of the main things was that they needed more trained staff and to retain this staff for a long time. So let's go to the conclusion where we see that the problems and the issues and the involvement, they are very alike in the cancer registries in all parts of the world. So we understand each other. The cancer registries, they know what the difficult points are. And the need for data also seems to be rather comparable. There is a need to innovate. There is a need for training. We need to expand our activities. And we want to have a better reporting. This is what we need to do together with clinicians, with government, with epidemiologists, with the cancer registries, if we want to be important in cancer control. And as said before, when started, together we can move forward and we can go further together. And I think that the expression of Mr. Armstrong is still really alive. The cancer registry is essential to cancer control, and cancer control is essential to even the survival of the cancer registry. So I thank you very much for your attention.
Thank you, Elizabeth. That was excellent and a lot of data, which needs some time to digest. But we will have some time after Dr. O'Sullivan for question and answers and as well as a panel discussion. And we'll come back to some of those points. So I'll hand over now to Dr. O'Sullivan, who's going to talk about both the stakeholders survey and the initial procedure with regard to focus group discussions of stakeholders. So Brian O'Sullivan, thank you.
Am I working here? Am I up and running? Not showing here. Thanks very much, Jim, and thank you everybody for your involvement in this. So I'm going to discuss the stakeholders group, which is a sort of an unusual name, and I'll explain why it's called the stakeholders. It's work we've been addressing for about the last 2 years or longer, with multiple calls on a standard schedule throughout that period of time, because there have been many different components to what was needed to get this work done. And it is unfortunately still preliminary, but I'm pleased to share some of it with you. You can see the main people involved mentioned there. With some people are involved directly in UICC, others are part of, for example, Tim Helliwell's at ICCR, and Jane Marr is not involved with UICC, but she's a very effective collaborator in some of these areas related especially to patient support. So I won't dwell on this too much, but I want to thank everybody who also completed the questionnaire that I'm going to present in a moment, at least some of the results from it, because without your help, it would not have been possible. To go ahead, what do I do? So, I got this thing here. Okay, so the objectives of the project is, I've just got them summarized here on these 3 bullets. We wanted to determine what prognostic and outcome information is important to different professional groups and stakeholders for improving their efforts in cancer control. We also appreciated that different stakeholders involved in cancer, from diagnosis to treatment, surveillance and support, may have different perspectives and requirements and roles, and therefore may have different needs to some degree, or at least maybe more emphasis on some needs rather than not having an interest in an area. And I'll show you what I mean by that in a moment. And we also wanted to make recommendations regarding the most important prognostic factors and outcomes to be monitored by the cancer system. So there's a couple of issues here. There's a major assumption, and there's also hypothesis. The major assumption is that we all believe in TNM and prognostic factor activities, and that these are stable and universally accepted. And they should come out during the questionnaire. We should see that there's a good acceptance of this whole domain. But different groups have different opportunities to determine, collect, report, and use TNM and prognostic factors and outcome information. So that's really at the kernel of this, the crux of this particular survey, to try and address that. And the hypothesis is that different groups have different needs pertaining to the goals that I've just mentioned above. So, for example, a cancer registrar versus an oncologist may have different requirements for their work, and we wanted to try and get at that area. The methods that we used for this was a global survey of different stakeholders internationally, and then also, as Dr. Gospodarowicz already mentioned, 5 focus groups of medical specialties who direct care, and that is something that we're still working on, but I will try to comment on that towards the end of my session. But the structure of the survey that was undertaken, and you can see it here, there was information at the start. I'll talk a little bit about the different components. There's a description of the respondents, which of course is just standard. And then there's addressing the prognostic factors in the way Dr. Brierley has already described. with the tumor, the patient, and the environment or setting of the treatment. And then the diagnostic investigation and treatment that a patient should normally go under, and also focus on the outcomes that may be collected. And what we wanted to find out is what people felt, how much they needed to have this information, rather than whether that's important or not. But we wanted to find out what they needed to do their job in the clinic, or in their various aspects related to cancer. So that's what's really summarized here. We want to understand the prognostic factors and outcomes that each person considered important for their work. And responding, we asked them to consider their own work rather than the general context of cancer control. So in an ideal world, what would you like to have? What do you need to get your work done? And that was really the focus of both survey as well as the focus group discussions, which are ongoing. So here are the intended respondents. We put these 9 different groups of stakeholders, as Dr. Gaspardaros has already mentioned. You can see them all identified here. Some of them are people who directly give care, others are in the support area, palliative care. There's also nursing and allied health, patient support groups, and palliative care groups, and then health services, epidemiology, and cancer registry, and of course, pathologists who we rely on to make the diagnosis. And for the survey, we wanted to try and get 50 candidates within each stakeholder group. So that would be in total 5 times 9, whatever that comes out at, 450, I guess, in terms of the number of people that we would survey. We wanted to focus, this was the big challenge, on geographic diversity. We didn't want to just go and get North American and European and maybe Australian, where we probably could get relatively easily. We wanted to get it across the world. And we also wanted to go beyond academic specialists, not just focusing on the big cancer centers, but also in the community as well, as much as we could. So that was a big challenge. It took us a long time to put the population together for the survey. Here are the countries specified by respondents. You'll notice that some of them are quite small in terms of the numbers, but they do cross-sect a huge amount of the world in terms of where we reached out in terms of the breadth of this survey. And if you like to look at maps more than lists, you can see them here in terms of where we reached out. And we thank everybody for your responses, which have made this feasible. So just to make a couple of comments about the demographics of the respondents, you can see they're fairly equal for gender, men and women. And you can see that they're a relatively experienced group, with 56% having more than 20 years of experience in their profession in oncology. So this is a good group of people who know about cancer. We also asked this very important question, which you can see on the left, because it's going to be the basis for how I present the data. We asked, do you have active clinical practice, or are you involved in decisions that impact individual patients? And we call that group the practitioners when our practice group, when you'll see the data as I show it. And for the people who do not do that, there were 32% of the population who responded said no, and they would be involved in other aspects of cancer management. Obviously all quite essential, and I already mentioned many of them, with epidemiology, registry, health services, nursing and allied health, although there's overlap, as you can imagine, as well as patient and patient advocates. The other box that you can see is a breakdown by the World Bank income level regions. This is here simply because I do try to break down the data according to this for some of the questions, not for all of them, because we didn't have time. But and in fact, we've even just this morning, in fact, we decided to lump the 2 lower groups, lower middle income and low income, together as one group, because the numbers were quite small. You can see there's only 8 in the low income population there. So they've been lumped together. So we have 3 regions that we will try to show you a little bit of data, not a lot, but it is interesting just to reflect on their situation as well. So the regions you can see here, North America, 21%, Asia and Australasia, 27%, Latin America and the Caribbean, 20%, Europe 15%, Middle East smaller 4%, Sub-Saharan Africa 12%. And so the total number is 246 respondents, and you can see the stakeholder groups listed there. And the response rate on this was not quite as good as Dr. Van Erken's study, but it came in at 43% for this group. And we only just got the results relatively recently, within literally the last 6 weeks or so. Here they are broken out. Probably doesn't help a lot to look at that, but I have addressed who are in what we call the non-practicing group, which are those who do not direct patient care specifically as their normal activity. And you can see they're made up predominantly of epidemiology, cancer registry, health services, nursing and allied health, although they also will be involved in practice, and then also patient and patient support groups. And the others are what you would expect with medical, radiation and surgical oncologists, pathologists, palliative medicine, who would carry on most of the activity in terms of directing patient care or diagnosing cancer to subsequently direct patient care. So the first section here in terms of prognostic factor area that I mentioned we will talk about is looking at tumor. And we looked at the aspect of cancer diagnosis from the point of view of the site, the type of cancer, using WHO classification, the anatomic disease extent, which of course usually by the TNM stage, but there could be others, and tumor characteristics. We often refer to that as the tumor profile at diagnosis, characterized by grade, by molecular characters or factors that are needed for practice guidelines, as opposed to molecular factors that might be relevant to your practice, but are not actually part of guidelines. And then finally, serum tumor markers. And I've shown examples of those right now. Classic one, of course, being PSA. So we look at the data here, and I've tried to just give a couple of comments here. I put these brackets around these areas, so we will collapse 4 and 5 in terms of the 5-scale method that we use to collect the data in terms of people's need to express their need for the different components. With all those factors that I'd mentioned in the last slide. So the site, the histology, the stage, also distinguishing clinical versus pathologic stage, tumor grade, the molecular factors, the additional molecular factors, and the serum markers. And these are divided into the practicing versus the non-practicing that we've already discussed. And as I've said, we lump the 4 and 5s together in terms of being extremely important or very important to their practice. And so to try and show the data a little bit better than this, because it's a little bit dull looking, I've used a sort of a standard color coding system where the green is where there's no difference between the practicing versus the non-practicing, and the red distinguishes areas where there really is a difference, which is at least 10% difference between them. But what I want to emphasize when you look at this slide and all the slides that follow is that there are 2 stories in here. There's the story about people needing these things, and you can see even when they're not as obviously needed by this group compared to this group, in other words, the non-practicing versus the practicing, they still need them. These would correspond to agreement on a Delphi process if you're looking for consensus. So it's not like they don't want these. It's an important distinction. It's not like they don't require them. So there's a very strong support for these, and especially for stage, for the histology, and the site of origin. What is also interesting to reflect on is all of these factors here, distinguishing clinical and pathologic, tumor grade, and molecular factors are all things that generally physicians need to have if they're going to treat a patient in the way they want, which they're probably not as important to non-practicing people. So that would be a reason why there might be a difference between them. And similarly, you get some aspects of that with the additional molecular and markers probably not being reflective in an overall survey. You need to go into the diagnosis, and this is where the focus groups will probably bring out data like this for different individual diseases, such as prostate cancer would need PSA, for example. So let's move on to the next one, which is the patient. And you can see all these factors here that we asked about. and they're going to come up on the slide in a moment. The gender, age, race, performance status, comorbidity, immunosuppression, pre-existing medical problems, social habits that might influence outcome independent of the cancer, and family history of cancer. And here you are, the same pattern. You can see it's not so easy to, you have to kind of scrutinize the slide, but I'm going to use the color system again. And you can see that there's again, very strong wish to have these factors, but not so much in, and I've used red to indicate which group is showing their preference for them compared to the other group. So here the practitioners they want to know about comorbidity, immunosuppression, and pre-existing medical because they need these for treating patients. Whereas these would not be as important for people who are not actually treating patients. It doesn't mean that they don't think they're important. They still are supporting them, but they are not seeing them as being as critically important the way it does to the practitioners. And then there are some kind of interesting things that put in this kind of funny color here about race, which is always a bit of a problem as to whether it's collected or not, and with the politically correct issue about it and so forth. So it's I think people are probably a little ambivalent about it, and it seems to come out in both the practitioners and the non-practicing respondents. Social habits and family history are very similar for both groups. And as I mentioned, the other gender, age, and performance status being very similar for both of them. So again, strong support for having these factors being available and that they need them for their work. This bracket here shows one group that has more than a 20% difference in the comparison between the two groups. And this refers to the immunosuppression, again, being most dominant for doctors who have to treat patients with immunosuppression, which is a big problem in terms of delivering care. So let's move on to the environment of the cancer treatment setting. Dr. Brierley already described this in some detail, what the treatment setting is, and also the social determinants of health of a patient, looking at these various attributes. And we ask questions about each one of these. One being the type of hospital versus a cancer center, another being an academic versus a university or community or district hospital, and then the level of education, the housing circumstance, and the level of income for the patient themselves, plus whether they live alone or not, medical insurance and expense coverages. So here's the data again, same method, and we'll go straight to the colors, and a lot of sense about reasonable support, although the treating doctors are not as strong about these areas. They don't seem to need this to treat. They will treat, even though they're coming in around the 60% area. They're not so much worried about the income and the housing and so forth. They obviously need to be treated. But you'll notice that for people who are not practicing and are involved in other areas, in registry and health services and so forth, they regard these as quite important. This is something that they need for their work, which probably for what we saw from Elizabeth a moment ago, they're probably not getting it. But this is what they would like. They would like this kind of information as part of the information that's available to them. And that's why I've got the red down here. They are dominating in their preference about some attributes over the people who are treating, who are delivering cancer treatment. So they have a stronger view about the level of education of the patient, the level of income of the patient, and the social support, and the medical insurance of a patient compared to the actual direct practitioners. And you can see nobody really cares about, they think it's important, but they're not any different between whether it should be a cancer treatment center or a regular hospital or an academic versus university. There seems to be some view that that's maybe good information to have, but there's no difference between non-practicing and practicing oncology professionals. So we move. Before I go to the next area, I just thought I'd put this in as another form of triage of the way we might see a difference. And I've got the World Bank strata here for preferences for, again, collapsed into that number 4 and 5 preferences. And again, focusing on what do they need for their work. And you can see it's not that different between the lower and middle income, I put lower, middle, and low income countries together, as you can see, to bring the numbers out, because there are only 8 in the low income. But there is a little bit of difference maybe in academic versus community, education of the patient, and income. But you have to remember that the confidence limits on this probably are not significant. I mean, they probably are wide, and any significance testing would not be significant because of the smaller numbers. And these basically reflect very similar to what we saw on the last slide for the general group. But let's look at some aspects of diagnostic investigation and treatment. How was the patient investigated? Do you need to know what kind of imaging or pathology was documented when you're taking on the patient for treatment? Do you need to know if the diagnosis was a screen detected case or presented with symptoms prompting the diagnosis, or if there was a delay in getting the diagnosis? And then we also looked at some aspects of details of treatment, which I'll show in a moment. So first, looking at the type of imaging and pathology, again, the practitioners are way ahead in wanting this because they really need this to actually treat patients. So they need access to the type of pathology and imaging that was done. They're not so interested in screen detection, and that also does not seem to influence non-practitioners. They are interested much more in symptoms, but not to the same degree as with imaging and pathology. And there's no difference between the practicing and non-practicing group in that particular sphere. So in terms of the diagnostic aspects, in terms of the treatment aspects, if the patient was treated, do you need to know the dose and fields and volumes of radiotherapy? You need to know the type of cancer operation that was done, and you need to know the type of systemic treatment that was delivered. And also, we're going to ask about this concept that Dr. Brierley already mentioned about the scenario, the idea of an initial presentation versus a recurrence versus a new cancer. So we will show you the data for those right now. Again, the same idea. We're going to go to color-coded, make it easier. And you can see that there's a very strong interest among practitioners to know what kind of surgery took place with 90%, and also with chemotherapy with 85% wanting that information. And practitioners also, 94% want to know if the patient had received treatment before, which is very similar for non-practicing. The other aspects are not quite as strong for the non-practicing, and that's why I've got them in red here. Because they amount to at least 10 or more percent difference between them. And this one here, in terms of the details of radiotherapy, I don't know if this is because people find radiotherapy somewhat of a black box and they kind of don't ask for it because they're not involved in it. But there's certainly about a 30% absolute difference between practitioners and non-practitioners with regard to what kind of radiotherapy did the patient receive. Which is actually quite important, because if you want to retreat a patient, or your options for management often revolve around the idea of, can you do it again? And it may be a big challenge. And that's something that people who have to treat with radiotherapy certainly would have to deal with. But surgeons also would need to know that information as well. Do they have to do a big operation, or can they be facilitated with radiotherapy as well? So if we move on then to the treatment scenarios, so do they want to separate untreated cases compared to previously treated? In other words, fresh cases or recurrent cases? And again, you can see very strong view among the practitioners that should be the case. They would want that information. It's also strong among non-practicing. The registries and all would probably want that information, although there's quite a difference between the two. And then whether you want multiple new cancers in the same patient, again, very strong among practitioners, but also strong among the non-practitioners as well. And then let's, for the final part, let's focus on outcomes. So there's a lot of different outcomes. Dr. Brierley has already mentioned that it's not a clear-cut area because so many different aspects are possible. And here's a list of 10 different outcomes that we ask about. The classic survival, response, the resection margin status following the surgery, because the resection margin status was not known before they had the surgery. It's an outcome after the surgery. Local regional control, distant recurrence, organ preservation, symptom relief, patient-reported outcome measures, and then the ability to get back to work and be employed. And then very importantly, especially in this modern era of very high toxic treatments, long-term toxicity of cancer treatment in the survivors. So here's the data and the same format. We'll go straight to the colors. You'll see a very substantial interest among practitioners in response, resection margins, local regional control, distant control, organ preservation, and symptom relief. You know, batting in the over 90% for many of these, and it's also supported by the non-practice practitioners, but it does have about a 20% difference in overall between the two, or more than that. You can see that overall survival is the dominant outcome for everybody. It's very strongly supported by both practitioners and non-practitioners, and you can also see that patient-reported outcomes have a good willingness in there. People need that for their work, and also addressing the issue of employment. Long-term toxicity is interesting because long-term toxicity does affect how people survive after treatment. So practitioners are very interested in that, and I was a little intrigued to see non-practitioners not being as interested with that 63% down there, especially since toxicity is part of patient-reported outcomes. So there's obviously something about the way we phrased the question that maybe we didn't catch the essence of it properly, because that probably shouldn't be as low as it is if they are supporting patient-reported outcomes, as they do, showing 77% in that column. And I've just put in the World Bank issues here to again show that really doesn't make much difference whether you're in a high income, an upper middle income, or a low, middle, and low income jurisdiction, except you can see resection margins here maybe, but all the others are very similar, not any real difference between them. So people in less privileged situations still are interested in these outcomes in the same way. So I've made a kind of a very ugly looking slide here to try and summarize what I've just shown you. So this is for the comparison of the practicing versus the non-practicing, which is about 2/3 to 1/3 of the group. The first thing is that there's a high statement of need for numerous prognostic factors and outcomes across the entire survey. Comes across very strongly. There's also additional variation between groups concerning what they need for their work, because it's not always going to be the same. And I showed many examples of that. You can look at tumor factors. Everyone wants site, histology, and stage, more than 90%. Practicing professionals want more detail, for example, clinical versus pathologic, or grade, or molecular diagnosis, all 90%. There was about a 10% or more difference compared to non-practitioners who still need it, 71 to 75%. So it's not like they didn't want it. They're still up there, they want it, but it's not as emphatic. And serum markers and non-guideline moleculars is less. They're around 50%, especially for the non-practitioners. Patient factors, gender seems to be quite important. Age is especially important, 90%. Performance status, important need for all. So these are across the board. And then the practicing group need more details about patient factors that influence treatment, including treatment tolerability, comorbidity, immunosuppression, prior medical problems. You can see it's 82 to 87% versus 59 to 69% in the comparison. And then the environment and social determinants of health. The non-practitioners need information on education, income, insurance of the patient, 75% range, which is not considered as strong by the practicing group. They're about 60%. Hospital type and academic setting are equally moderate in both groups, around 70%. Still okay. It still seems to be something they want. And social support is equal and strong, 75%. Housing is equal, but less emphasized, 60%. And then in terms of the outcomes area, so that was prognostic factors in the last slide. Again, we see the same concept. High statement of need for numerous prognostic factors and outcomes across the whole survey. additional variation among two groups relating to what they need to do their work. So for example, survival is universally important to everybody, 90% range, and patient-reported outcomes and return to work also very strong. Anatomic-based endpoints like response, local control, distant recurrence, symptom relief, et cetera, all have the highest need in the practicing group, 90%. They're still valued, however, in non-practicing, 50 to the low 70%, with some having this, I show that one with the large squares, more than 20% difference between the non-practicing and the practicing. So that's the results of the survey and what we've seen so far. I think the two bullets at the top of this slide and the last slide kind of summarize the whole story. There is definitely a strong statement of need from people for different aspects that I think we all recognize. I don't think this is a huge surprise to most of us. In fact, we'd be disappointed if it didn't come out like that. And then we also see the additional variation among the two groups relating to what they actually need for their work, which is going to change depending on the specialty. So thank you.
Thank you very much, Brian. Is there anything you want to say about the stakeholders, or really it's still in development?
About the focus group? Well, I can make a comment about what it's about, so it's not so mysterious. Sure. So stop. Yeah, okay. Dr. Brierley just asked me to make some comments about focus groups. So we've chosen 5 different disease areas to try and bring out different aspects of different types of management and also the natural history of diseases. So we've chosen one hematologic disease, which is multiple myeloma. We've got prostate cancer and breast cancer as two obviously standard common diseases with a lot of different aspects to them. Colon cancer, cervix as well. So myeloma, breast, colon cancer, cervix, and prostate. And we're asking, and we've done one focus group so far, which was in prostate, but we ran out of time before the meeting here. It's very hard to schedule it because what we're trying to do is go for geographic diversity, and there's people in Australia and across different parts of the world, and to get the time right is very, very difficult and complicated. Maybe more difficult than we had anticipated. Although that does not mean I don't mean to say that people were not supportive of joining us. Just that to get the calendar right was very difficult, especially this time of the year. So what we wanted to do with these focus groups was again emphasize on the issue of what practitioners need for their work in their clinical care of patients. And we wanted to have 2 surgeons, 2 radiation oncologists, 2 medical oncologists, and 2 pathologists for each one. Obviously, we wouldn't have a surgeon for the myeloma one, but the general idea is to have 2 experts who either diagnose or are involved in the direct delivery of care. And in order to run these focus groups, we've drafted 2 questions that we ask the group, and then we go around the table to see what everybody thinks. Since actually I did the prostate one recently, and it was quite an enjoyable type of activity. Elizabeth and I both did the prostate one, and it went quite quickly. I think they actually liked it as well. But what the 2 questions that we asked were, the first one is, what do you need to provide the best care for your practice, or in your practice? And it's about, what is needed. Not so much what do you have right now, but what is needed to be able to deliver the best care that you can do. And so we went around the table several times with all specialties being asked for their opinion. And then after that, so that was really related to the treatment, but then we wanted to also bring them back to focus on quality. And with that, of course, you can't measure quality without having an outcome. So it would also address outcomes. So the second question, which is on improving quality, is, in your practice, what needs to be monitored to improve quality and outcome? And we also asked, what outcomes do you need to collect or to address to improve quality? So that was an interesting discussion, and we really haven't really collected the data together for that first focus group, but that will be the sort of pattern that we use to go through the other 4 sites, and we will hope to be able to enrich the story with the information we get from these, because the people we're asking are true experts in oncology, and they have good views about this, and hopefully that will be very contributory to trying to address the needs for what needs to be collected and addressed to improve both treatment but also outcome for these patients.
Thank you, Brian. And I would like to reiterate both you and Elizabeth thanking everybody who took part in these surveys, both in helping developing the questionnaires and also for those who answered and replied. I think there's an awful lot of data in both surveys that we need to absorb and analyze a little bit more depth, but there's an awful lot of fascinating data there. At this stage, I'm going to hand over to Mary Gospodarowicz, who is going to chair a panel discussion and also question and answers as well. So please, if you're taking part remotely, you can use the question and answer section in the Zoom for any questions that you have for the panel. So I'll hand over now to Dr. Gospodarowicz.
Thanks, Jim. So maybe we'll invite several people to participate in the discussion. Yourself, Jim, Lisbeth, Brian O'Sullivan, Brian Roos, and Marion Pineros. And maybe the first questions to you, Jim. When we did the expert interviews, were you surprised by the results?
I don't think so. I mean, I think it's what we expect, really. And I think the results of the expert interviews are really reflected both in the surveys, in that everybody wants more information, and that information is both prognostic factors and outcomes. There's a different emphasis, as Brian showed, by how much people want things, but everybody wants a lot more information and a lot more data.
We had amongst experts people who were not oncologists, were not clinicians, were interested in health services research, cancer control, some clinicians, and there was kind of a unanimous opinion about the importance of doing this work. Maybe I'll go to Lisbeth next, and in the your 269 cancer registries, how did you select the registries to which we sent the survey?
Yes, we had a working group, and the working group gave input on that. That is the first thing. We have cancer registries all over the world, so we wanted really a global representation. We wanted very small cancer registries. We wanted very large cancer registries. We wanted also cancer registries that are organized in a more national way or regional, that are covering only a region of the nation. Let's say that we wanted very sophisticated cancer registries that are really taking part in all the aspects of, or almost all aspects of, cancer control. And therefore, we really needed the help of IARC, NACER, the African Cancer Registry Network, to have a good idea. And then we randomly selected from all these together to come to a good overview. And I think that if we see the distributions of the population covered, of the activities they are doing, if they are recognized also by the IARC, and that data are published in cancer incidence in 5 continents, I think that we are very happy that everybody wanted to participate, because I think it's not easy to participate if you have very low resources, if you are struggling to survive as cancer registry. But we hope to have given visibility to all of this group. And that was a bit our working, that's why we appreciate it so much, do it together.
I don't remember how many cancer registries there are in the world, but I think Marion may know how many contribute to to the Globocan data. I think it's more than 600.
To CI5, which is the cancer incidence in 5 continents, we received around 800.
So when it's 800 and we
data set.
surveyed 269, so it's more than 30%. We have to say that I remember in the discussions, we sort of de-emphasized getting many regional registries from Europe and North America, because they would sort of thwart the proportion of the registries from South America, Asia, and especially Africa. So we wanted to have better proportion. There's always a lot of debate, and we had a lot of debate how much to ask, because you can ask hundreds of questions. And I think what we decided is to limit the number of questions, to not to sort of put people off, and to sort of optimize the response rate. And were you pleased with the response rate, or was it what you anticipated, Lisbeth?
Well, if you look to the global survey responses, I think that we may, in that sense, may be very happy with that. Of course, being positive, I would have liked that every cancer registry would have taken the opportunity to answer, because it gives the visibility to them. So that's maybe a pity, but I think that we have a good representation, and I think that all the ideas came up from the registries that we have surveyed. So I think in that sense, I can really live with the response rate, and it has been a really a good distribution of different powers in cancer registration and cancer registries that are setting up. So that levels off our results, I think. So I was very happy with it. Yeah.
I know that you made a lot of comments, and we placed a lot of emphasis on collecting stage of disease. And, you know, at the UICC, I think we've been working at it for about 20 years or 25 years to really promote the collection of stage by registries. And can we maybe comment a little more about, I was surprised when I saw the results by the number of registries collect the stage, but then when you ask for details about the quality and the number of diseases that are staged and proportion of patients, can you comment a little bit about how it's evolving?
The main issue is here, how do we collect this information and where does it have to come from? So it is known that it's really an investment for the cancer registry to pick it up. You have cancer registries that work with an active system where data managers go into the medical files, try to find the data. So then the first question is that information really available in the medical files? Can it be found? That is the first thing. Even for me, when I'm speaking for Belgium, for example, we know that hospitals do not cover 90 to 100% of the stage information. We always have to go back and ask for more information. So we know that is intensive. It is a complex system for data managers, so there the training is needed. And it is an effort. If you get passive information, then you have to accept the information you get, and then it is included or not included. So it depends really on a close collaboration between the hospitals, the physicians, and the data managers. The data managers need training to capture the data, or need techniques to be able to capture, need more documents, need the access to data. We have seen in the text also that sometimes they have lack of access to data or are denied access. And we cannot underestimate that problem either. So I can understand the huge variability in results in stage information available. There are a lot of solutions, but there are indeed a lot of challenges.
There's still lots of work for us. I know that, you know, when we talked initially a number of years ago to IARC about cancer registration in Africa, we were told that the collecting stage in Africa is just not an option because it's too difficult. But I think we've done some work towards it. And Marion, I was wondering whether you could mention about, you know, the progress of education and advocacy and stimulating, first of all, development of cancer registries in Africa, but also collection of stage and how it's become feasible.
Okay, so one of the main limitations, as Lisbeth was saying, is the quality of the clinical record. if we don't have in settings where we have to go through paper clinical records and the physician does not put it down, it becomes extremely difficult. So if the priority has been for registries to have high quality cancer incidence data by site and type of cancer, that has been like the major priority. Of course, the more time elapses, we really know that if you have incidence and survival, stage is critical to explain not only survival, but to explain also cancer control actions. So during the last time, and the people accompanying me in this table, we have, I think we met some 10 years ago to discuss, some 8 years ago, to start discussing again the topic, how can we promote data collection of stage? And we have worked a little bit on from IARC, but also UICC to have some alternatives, which I probably will address in the next talk, in the next session. But so we have developed Essential TNM, which is a simplified comparative TNM stage for registrars when the information is not complete in the clinical record. And we have developed also the CAN Staging Plus, together with several partners, of course, that is an electronic help, online help to stage. So I think that slowly and mainly all the effort of the African Registry Network has shown that it is possible to start having stage data, and they have shown it, I think, quite extensively in the last years with some publications.
There are some questions coming online. A lot of congratulations from people on the work and information being provided. There's one question is, are there any registry that are exploring the use of AI to collect staging and other prognostic information? I think we'll address it in the second part of the discussion. We'll be talking all about the AI and newest way to address the issues. And then Sherman is asking, is it possible that some respondents, in particular non-practitioners, consider feasibility or sustainability of collecting certain data elements in formulating their answers? Sherman, it was one of our major issues that we discussed in the project over and over again. We emphasized on numerous occasions that we're asking people to tell us what they need in their practice, rather than what's available to them, and sort of hoping that they would not consider the sustainability and feasibility, but would they say what they need? Brian, do you want to comment of how do you think that could affect the answers?
Well, it certainly could affect the answers, because the question was very clearly, as I mentioned at the start, directed in that way. It was to try and ignore what you may not have right now, but to think about what you need to do your job as well as you can. And it shouldn't affect the answer unless you are, reticent to state that for some reason, which I guess there are some. You could imagine maybe some reasons why some people might not want to say it, but these are anonymous questionnaires, so it shouldn't be a problem. And also the focus groups are also anonymous, and they're all, by the way, this is all ethics approved procedure, so it's not like there's any worry that way at all. I guess the answer, in a sense, is contrived a little bit because of this artificial scenario that we've put in place. But I believe that that's actually, they were being honest in saying what they really want, what they really need to have for both outcome assessment, but also for the care of their patients. And there was nothing that was came across as ridiculous there. And there's a whole pile of open-ended material that I didn't even talk about, which is also very constructive, but it's harder to analyze. So I'm not sure if that answers the question, or whether that is.
It's a potential confounder, right? Yeah. But we did try to. So we thought about this as being a potential problem. The response rate in your stakeholder survey was 43%. Are you surprised?
I am actually. I didn't think it would be as good.
Yeah, I don't think any of us thought it was good. As I reflect on the stakeholder survey, we had 9 stakeholders groups. We had hypotheses that there will be some differences between the stakeholders group. One can always look back and say, why didn't we approach 2,000 stakeholders rather than fewer? But it took us months and months to identify people because you actually have to find them. You find their email addresses. They have to be active. You have to invite them, and we didn't want to just invite our friends. So we went to the cancer centers. We went to the people who are involved in practice guidelines development, who are participating in societies. We tried to be as unbiased as we could in finding people. For example, to identify nurses, we went through the International Association of Nurses in Oncology, who then approached their membership and asked them to volunteer to be invited to complete the survey. So they didn't give us contact information. They just send it to their constituents and say, please, if you are interested in helping UICC, please send your email address. And we were quite surprised by the number of volunteers that came forward. There's always a sort of yin and yang between making the survey bigger, having more participants, having more questions, and the completion rate.
I noticed there's a question in the chat about somebody who's obviously from a country that I won't mention the country, but everybody, it doesn't matter. Countries, that makes no difference. But this person said that there was nobody from that country where he obviously or she works, and the problem there is maybe we sent multiple surveys to that region, but they didn't get one back. So it's not a question. It's yin and yang, as you say. It's both. It works both ways.
We focus on parts of the world and not to include individual countries. In fact, I was quite surprised when I saw the map of the countries, how diverse the population and reach was.
No, it's extraordinary. Yeah.
So, Brian, our hypothesis was that different stakeholders place different level of importance on various factors. To me, the differences were not huge. Were you surprised, and how do you interpret that?
Well, I think it's dominated by the fact that the different parameters are still things that people think are important for looking after cancer patients and for outcome assessment of cancer patients. So it's not like, they were going to diminish into a level of, rarity or anything. They're still there. So it's just that they happen to have a little bit more robustness maybe among people who actually deliver treatment for a particular issue, and they need that information for their treatment maybe. But the others also still advocated for that particular element. So I think that probably, it wasn't like a yes or no, that they still wanted it. They just didn't want it as much. So I think that's a reasonable explanation for it, but there's no other way to kind of interpret it, I don't think.
Brian, Ruth, are you surprised that so many people want molecular factors and other additional molecular factors that are not even in practice guidelines as they responded?
So initially, the ones that are in practice guidelines, you sort of, it's obvious that they would be important, but the ones that aren't in practice guidelines, you think, well, why would anyone want those? But then when you think about it a bit further, there's a lag in the development of practice guidelines being developed. So clinicians are using factors that are being published all the time before they reach the threshold of getting into guidance. So that's obviously going to be a challenge for cancer registry, because that they need to be ahead of the game and ahead of guidelines being written to be able to collect that data as required.
We had a long discussion. It took a lot of work to sort of not to be biased by feasibility, and sustainability and availability of resources. And we focused on what do people need? Because the challenge that was in front of us is what do you need to collect to improve global cancer control, to improve outcomes, to improve results? So those are the questions that we asked. And to a certain extent, you have to be very careful. People do revert to saying how difficult it is. But I think progress is being made. And those of us who've been at it for a while know that, collecting certain information 20, 30 years ago was not feasible. The progress in cancer registration is enormous as far as reach. Now, I think what we're calling for the progress in depth of the information being collected. Do you have any of the panelists any wish list of what information would you like to have more of in order to sort of accelerate progress? And I'll just start with Brian Roos, go to Brian O'Sullivan, Marion, and then rest.
So the thing that shocked me in the survey, I think, was the non-practicing request for both race and income was relatively low, and most studies that looked at either race or income levels have shown that is a big indicator of outcome, and so I was quite shocked that they weren't asking for that. And I wonder if that does come back to Sherban's question of actually, is it because that information is difficult to get, and so therefore they're not currently using that information, therefore they don't see that they need that information, and so that may be something we need to tackle, and to say, actually, you do need this information and you don't have it, but we need to work on ways. And if that legislative, it's difficult to get hold of race data and so on, that we need to work with organisations to get past that at that point.
There's a sort of related question in the chat, which is about, it was really directed to Brian, but I think it's a general question. Is there some conflict between data recording and data protection regarding social determinants of health? But it's just across the board in that, and it came out as far back as the interviews, that data protection and legislation is a barrier to collecting some of the information.
Shouldn't have affected our survey because we said.
Oh, it shouldn't have affected the survey, but this was a question
it's a problem.
Is if we want to collect social determinants of health, how do we do it if there's data protection issues?
Correct.
And I don't think we can solve that situation, unfortunately.
Yeah, but social determinants of health also includes just the treatment,
Well, yes, the treatment is a different matter, but I mean, some things like race and income, perhaps. I mean, there may be other sources where that data can come from, but it is a confounding issue, and it is a barrier to collecting some of the data that we want.
Okay, Brian, what would you like more of?
Well, I'm going to be a little bit provocative and outrageous because
How unusual.
Yeah, but I think it's sad that registries don't have local control and distant metastases collected in the registry. I think that is not a hugely, maybe in different countries where it's very hard to get at, but these are basic things, radiology reports nowadays that show that are typed up and can be scanned, and the question on AI is interesting, and maybe there'll be a discussion about that this afternoon, but there's ways to collect data now that could do that. And I think it's very, very sad that we don't have such information here in 2023 about local control and distant metastases in the cancer registry. So that.
Marian?
Well, rather than going into depth, I would really like that any country has at least one good quality functioning registry. So which is not the case, and high quality registries are covering, at least in Africa, Latin America, and most parts of Asia, less than 10% of the population. So there's a huge inequality there.
It's very interesting because you reflect what I'm engaged in the Lancet Commission on Cancer and Health System, and the same we have the same discussion. Before you sort of talk about precision medicine and circulating tumor DNA and multi-cancer early detection, why don't you just get the access to care and equity right? And also hundreds of hours of discussion, and we think that what we should be doing is doing both, catching up, so going for equity, but also raising the bar for people who perform, because I don't think there's any cancer registry that would consider itself perfect right now. So how can we scale up the registries that have a lot and also catch up in the breadth? So Lisbeth, over to you. What would you like, you're a director of cancer registry, what would you like to do more of?
Wish list is better information on biomarkers, as we all feel that this is becoming a major issue to have good stratification of the different tumors. That is the first thing. So we are very happy that this is also integrated now in the classification, which is available for all the cancer registries. And if that information on biomarkers is available in, for example, in the pathology reports, then it can be extracted manually with more sophisticated techniques. But I really believe in that. I also believe that it's a challenge to capture that data. And a second for me is the answers in the survey on treatment were on nature of initial treatment. And this is a long way to go to capture more data that are clinically relevant and where the clinicians say, this is important for us. So not only the modalities like radiotherapy, chemotherapy, surgery, whatever, but going into more detail whenever possible. But I agree also very much with Marion that first build a good structure and then go up into details and work out and show, because when showing data, when showing results, this motivates the circle of people that have to put their energy in going further for registration. And I also agree with the colleague Corrie, who reacts on socioeconomic parameters. We always have to question, where can you get the data? And this is not so easy that, as she says, for socioeconomic parameters, where do you have to find it? It's not always in a structured way. If it's written down in a hospital file, in a medical file, you really need to capture it somewhere more consistent and in a good coverage, because if you lack 80% of the data, you will never be able to make conclusions. So I would make a plea for socioeconomic parameters, but taking into account what is legally possible. If sources are available, level up and scale up treatment details, because when data are used, they are getting better. And the biomarkers, that is a way for me to go and not to stop. So maybe a big wish list.
Tim?
Well, I mean, if we look at the answer to Brian's survey, everybody wants everything, but progress has been made, although perhaps a bit too slowly than we'd like. But as you said, with the number of registries increasing by year, registries being able to collect staging information, and it is happening. But I think Brian's point about local control and metastatic disease should be very feasible, and that may be the next thing to focus on. Should you have a step approach? Because I don't think you can get everything everywhere unless we find out this afternoon that AI is going to solve all our problems.
Thank you. There's a question in Q&A. How successful have you been with staging information in population-based cancer registries? Seems certainly easier with hospital or specialty registries. To Lisbeth and Brian Roos, because you both have information on working with cancer registries.
There are numerous publications, I think, on the first thing that came.
In Belgium.
Yeah. Oh, in Belgium, yes. Okay, we use it. We are very strict on that. We have a policy in Belgium also that hospitals get the kind of remuneration also for being in line with the cancer registration, and stage is one of them. That's maybe I'm a bit biased because I'm in the TNM committee, but we stress on that. That is the first thing. So that means that we can even make reports hospital-based for their outcome it is okay. It is mostly survival, it's post-operative mortality. It is the procedures that they are using. And there we always need the stage information. If you want to have an evaluation of the number of...
How complete is your stage capture in Belgium?
More than 80% for the tumors asked for, more than, and mostly 90%.
For
because we can take
all
back
diseases or just the top 10 tumors?
top 10. Yeah,
Top
but it's less good for, I'm sorry, Brian, for sarcoma and for the more rare tumors and the classifications that are not so often used. So that's true.
And what about the UK? I always think the UK collects everything.
So we try. And so I mean, I strictly speak, I can only speak for England, but actually it's broadly similar across Scotland, Wales, and Northern Ireland as well. So we do we collect 85% plus for the most common cancers, but there are definitely cancer types where it is harder to capture the stage. I can think of examples. So sarcoma is one, and sometimes the sarcoma staging system is difficult to apply to tumors in odd locations because of, if it's intra-abdominal, there's an element of it's supposed to cross the serosa, and it hasn't started in something which has a serosa. How do so causes challenges there. Mesothelioma is always very difficult to capture stage on unless it's very advanced, and so we end up with a very biased data set of just very advanced mesothelioma. And liver cancers, we always struggle to collect stage data on those as well. So but there's a spectrum from I think our lowest cancers are sort of in sort of 50%, but the bigger cancers are in the high 85.
I think there needs to be harmony between population-based cancer registries and also population-based cancer systems. If you don't have population-based cancer system, it's very difficult to capture the data. In Canada, where healthcare is provincial, in our province, a number of years ago, Cancer Care Ontario mandated stage collection. And at the beginning, everybody said, oh, it will never happen. It did. And in fact, they provided the cancer center and cancer region scorecard, and they gave you a scorecard, what proportion of your patient information that you see in your patients were staged. So I think something that seemed to be very difficult at the beginning, Jim, you can comment on that, became actually quite standard after an initial period. Again, you need to sort of reach to all groups of clinicians, and it's probably easier to implement for most common cancers than rare cancers, but with the right championship of what we had is sort of disease groups, the sort of, we can't remember what they call them, it's sort of, we had disease-specific groups of specialists that looked at data in Cancer Care Ontario that certainly improved the stage and data collection for even less common diseases.
Can I just make a comment? One of the things that, over many, many years that I've become fairly convinced about is that if you start doing something like this, you get better at it. The whole hardship of it is getting going. You don't know, you don't have an access to the parameters to stage or whatever the components are. You've forgotten what it should be. As Brian has just used some examples from sarcoma, which I do agree about mesothelioma, and also angiosarcoma, but most of them you can stage because I do it all the time. It's not a big deal, but it's just because I do it all the time. If I didn't do it all the time, it would be difficult. It would be troublesome for me to actually find what it is. And didn't they change the intra-abdominal one? And now it's more than 10 centimeters, more than 15 centimeters. All those things. If you don't do it, you don't know it. You can't do it easily. You tend to avoid it, and that's the problem. And it happens with all of these different scenarios that we're talking about. If you don't do it, you won't be good at it. And therefore, if you're not good at it, you probably will not do it.
And then by doing it, you should start with staging cancers that are amenable to early detection and to screening.
Yeah.
So then you start there, but also it's a key factor that the population-based registry interacts with the clinicians and shows them the data. once showing them and saying, okay, we have only stage 60% or only stage 40%,
It improves.
it improves with time. It takes time. But I think that is
I think
crucial
that's a
part.
very important point. The Ontario program that Mary mentioned started really because although colorectal screening was happening, it wasn't a formal process. So they introduced a formal process and they realized they need to have good stage data to show that it was worthwhile. And that led to the development of this. And also once they decided to do certain sites, other centers, and certainly this was across when across the country, provinces decided, well, if we're doing these sites, we might as well do more. And as Brian said, that if you start and then keep on building on, you can build on that, but you've got to get started. And one of the question was starting is, things tend to be better in hospitals than in provincial cancer databases, but I think it reflects one of the other things that came out certainly in the interviews is how do you improve data collection and collaboration between those who are collecting the data, and how can you combine the data, and if the hospitals have the staging data, then it should be able to get to the provincial cancer registries.
A couple of comments in the chat about collection of social determinants of health and other data and data linkages and how this would be helpful if there was a legal support, legal framework. And I think in your survey, Elizabeth, it came out loud and clear that where there's legislation, do you want to comment on that?
We had the three parts for the legislation, but we were a bit surprised that a high percentage of the responders had a specific legislation on cancer registration. But then there was a second level asking if cancer was mandatory, was a reportable disease, and there you really have differences. So that means that one, you have the site of the cancer registry that must do its job and got, let's say, a legal frame. But at the other hand, you need your sources to make cancer a reportable disease and making it, yes, not voluntary, but mandatory. And these two must join each other to have the full access to the data and the participation.
So I think basically what we've seen is that people involved in providing cancer care and control need this to improve cancer control. The registries are willing to collect the data, but those both institutions need to work together and together with other sources of data in order to sort of provide a comprehensive picture. I think we're going to come back to that in part 2 when we will talk about what is the need for data in today's cancer control ecosystem, and how can we make better predictions, better decisions with the data. So I'm really looking forward to part 2. We just have a few seconds to finish part 1, where we're going to have the what's our break? 15-minute break, so you can stretch your legs and we can get a glass of water, a cup of coffee. But I also wanted to thank everybody who put questions and any comments in the chat. And what I would like to encourage the participants, there's a lot of congratulatory messages, but what I'd like to encourage you is give us questions, because we're going to have further look at the data, and having your questions would help us. We're obviously going to share this recording with the participants. We can encourage you to share it with your constituents, with your colleagues, and get back to us with suggestions. And we certainly will publish the information and continue the work. So thank you all very much. And we're signing off for 15 minutes. Please don't forget to come back, especially the speakers. Thank you. And now we're on. So welcome back, everyone, to this part 2 of our webinar on cancer, prognostic factors, prognosis, prediction, outcomes. We had a very robust discussion in the first part on the work that our group has done on looking at capture of information by population-based and hospital-based cancer registries from all over the world. We also have discussed our project looking at the various stakeholders who need data to be collected. We talked about a survey of the 9 stakeholders groups. The analysis that was provided by Brian O'Sullivan, and we had quite an interesting and engaged panel discussion. So in the part 2, we're going to focus on 2 things. One is the progress in global initiative on cancer registration. And we're very honored and happy to have Marian Piñeros from IARC to tell us about this project. We then will have 2 guest invited presentations, one by Professor David Jeffrey on data for cancer control, and one by Professor Avi Goldfarb from the Rotman School of Management, University of Toronto. We're very happy that he agreed to join us on power and prediction. And then David Jeffrey will lead a panel discussion with Avi himself and Ali Berlin, who's worked with us before on prognosis and prediction. So without further ado, Marion, can you just, can we hear from you on the GICR? Thank you.
I'm sharing, but it's not sharing. Yeah. Is it complete now?
Yeah, it's up.
Okay. Okay, so
Presentation mode.
it is, yeah, it is. It just takes some time. So thank you very much, and thank you for the opportunity to show you a little bit about the Global Initiative for Cancer Registry Development. So for those that are not acquainted with IARC, and some may not be acquainted, IARC is a specialized cancer agency of WHO. We promote international collaboration in cancer research with an important focus of research in low and middle income countries. And for today's webinar, we are a global reference for cancer information. That's in our mandate. That very briefly, at the Cancer Surveillance Branch, where I am, the main programs of work are the 3 that you can see there. We do a lot of registry support to ensure that locally recorded data are of high quality and are available for cancer control and research. We manage the Global Cancer Observatory that consolidates and expands also IARC's role as a global reference for cancer data, and we have been improving in the late years, also expanding the topics that we are dealing with. And we conduct descriptive epidemiological research. And all comes together because the registry support is critical to have data to have in the global observatory, and those data are critical for research. So how did we came about the Global Initiative for Cancer Registry Development? The first important aspect is that we all recognize that there is an increasing cancer burden, that low and middle income countries are having even further transitions and increases that are bigger proportionally than in already developed countries, and that there is a need for cancer control, and that is a truth. We also, and I highlighted before in the discussion before, we have an immense inequity between less developed countries and more developed countries, even despite having a long history of cancer registration, and we still lack many, many countries without population-based cancer registries. We have also some opportunities, and you know that the political momentum prioritizes NCD's control. and among those cancer. And for cancer, WHO just recently launched 3 important global cancer initiatives, the one on childhood cancer, the one on breast cancer, and the one on cervical cancer. So these are more or less the background to the multi-partner global initiative for cancer registry development, which IARC coordinates. This is not showing, I'm not really well. Our vision at GICR is saving lives through better data. And I think that the symposium today is very, very good for highlighting this. We work through country leadership. In fact, it is countries, and we hope that it is the country that takes the lead on the actions. We work on a regional focus. With a regional focus, there are really some certain realities by region that we work with, and the global coordination that is done from IARC. In all of the hubs that I will show now, we have core functions, and the core functions are related with training. That is extremely important, as also Lisbeth just showed from the survey. We do directed support to a series of registries to help them in a targeted way. Once we have done, for example, site visits, we promote the networks on specific topics that are good for or important for cancer registration, and also the link of the data use with cancer control. So we also deal with governments and stakeholders that need to take action according to the data. Here you can see our GICR hubs, the 6 colors that you see, each one represents one of the hubs. And in each hub, we have a coordinating center, but we have also IARC centers of expertise, so-called also IARC GICR collaborating centers. In each hub, we have 3 or more collaborating centers. Here we can see, for example, the ones of the Mumbai hub that are located in Beijing, in Bangkok, in Korea, and in Japan. So these collaborating centers do it as a true base collaboration. They are either registries or universities or research institutions that have come in with GICR to help to promote training or to do specific research that can help to the goals of the GICR. So they really invest in GICR, mainly in kind and some with direct funding contributions. So I will present very briefly some of the key focus activities in which we are working that are the GICR net, some of the improvements and modernization in data capture and data abstraction, which is electronic medical health data linkages, and one of the streams of work that is done with what we call the GICR partner countries. Here you can see a picture of our GICR net data quality trainers. All of these are experts in data quality that we have trained in a master course and that help outreach in the specific regions they come from. And we maintain also the group. So we have developed a network of trainers in specific content areas that can assist the IARC hubs, mainly in delivering regional courses, but also in doing tailored support to registries. And with them, we have developed a set of facilitated slides and training material that are standard across the hubs. They can do some modifications or translate them, but they have been developed and we have agreed on standards about them. The GICR net trainers, they provide the support to registries and they contribute also to update or to improve the material and the exercises when needed. So far, we have had 5 counting from 2016 to now, to June 2021 was the last one, 5 master classes. The first one was CanRec, the second coding and staging, the third data quality, then data analysis, and then pediatric childhood cancer. And here we can see the number of trainees in each of them. So they are train the trainers, and they are also expected to help us expand the training with the elements that they have received. And we try to keep at least 1 or twice a year meetings, either virtual meetings or in person. That has not been possible due to the pandemic, but probably we are soon gathering some of the experts to keep also the network alive. We have been working this year and last year, funded by Bloomberg Philanthropies and the Data for Health Initiative, on a GICR e-learning training modules, which is e-learning material, 15 modules that you can see there. I will not enter into detail. And each of the modules include exercises, references, and summaries by module. They are at the moment in English, and we will launch this in the next month, probably the next month, and hope to do soon the translation to French and also to Spanish, so that we can expand more in the different hubs. And regarding modernization, we are well aware that many of the registries in low and middle income countries are working still very in so-called primitive form, but there are more and more in the hospitals and in clinical records are getting more and more electronic health records, and there is a need to do some innovations. So currently, one of our groups is working hardly to link, to make linkages between DHIS2, which is the District Health Information System that has been promoted in many of the hospitals, mainly in Asia by WHO, to link that with our program for registries, that is the CANREG 5. That is work that is going on currently. It is being led and developed by the Rwanda National Cancer Registries and is being currently piloted with some of the Caribbean hub countries. And we hope to have some global rollout in December. So far, the preliminary results are very good, and that would really facilitate a lot. Besides this, we know of some of the initiatives. Maybe we can comment later in the about what some registries are doing and are starting to use artificial intelligence and other means to improve data abstraction. The concept of the GICR partner country helps us also to focus on a certain number of countries that have either come to us or that we have selected for specific reasons, but where we see there is a commitment from the government in the countries, and that commitment somehow materializes having an agreement and measuring the progress towards specific goals. That means that in each of these GICR partner countries, the staff of the registries receive intensified training in specific aspects that are needed. We have follow-up that is carefully done, and we prioritize those countries also for mentorship. If possible, registry reports, it depends very much on the level of development of registration, but then we work also towards some dissemination of preliminary results and working with the governments to highlight what has been found so far. Here you can see some of our partner countries with whom we have signed an agreement that had compromised. And in the case, for example, of Mexico, this just to bring an example, we very recently published the preliminary data for cancer incidence in Mérida in Mexico. So you can see there is a long way from when we signed the agreement to when we have when we have results, and even before signing the agreement, there was already some work. Recently, some 2 years ago, we also have an agreement with St. Jude Children's Research Hospital so that we can use the GICR model, but to improve childhood cancer registration. There we have 3 streams of work. The first one is implementation in countries, where we hope and aim with those countries that we are working for the moment for, to have an action plan to improve cancer registration and specifically childhood cancer registration in that countries. We have done all the educational program, developing the masterclass material and trained people. That has been already replicated and duplicated in 3 courses. And we do some research activities, mainly in data sharing, which is very complex and even more important for childhood cancer, given the relatively rarity of some of the cancers. We are working in the definitions and what are the practices of registries regarding brain tumors, if they collect all the malignant, but also benignant tumors. And we are working on a stream of financial toxicity of childhood cancer in this specific child GICR project with the support of St. Jude. And I wanted to highlight, finally, very relevant to the work that we have been discussing and are discussing today, relevant to prognostic factors, also the relation of GICR with the WHO initiatives, in this case with the Global Breast Initiative. In Pillar 1, we see that one of the targets is to achieve diagnosis of at least 60% of invasive breast cancers at stage 1 or 2. So definitely, this is a strong support for registries to collect really cancer, not only by type and histological and morphology, but also by cancer stage, as we have highlighted in our cancer surveillance framework. And GICR, as I mentioned briefly before, we are working on improving stage data collection at the population level, mainly through these tools that you can see here. Essential TNM, we have developed a user's guide. This has been a work that started some 8 years ago or 7 years ago. Currently, we have 8 cancer sites. This is available in English, French, and Portuguese. It is available in the UICC webpage. It is available in the African network of cancer registries that has been very, very active working with us in this. And then it is available on GICR webpage. So it helps cancer registrars to abstract when the T, the N, or the M are not there, or when the TNM, the stage group, is not there. We have developed CanStaging Plus, and here some examples of research publications regarding stage that have been also the product of this work done in collaboration with the different registries, like, for example, this one on a validation, a recently, last week published validation of essential TNM exercise, which was done by the African Cancer Registry Network. So to finalize, and all the challenges and needs, it's no doubt that cancer and NCDs are increasing. We are expecting an increase of 67% from 2020 to 2040. We will have more than 30 million new cancer cases diagnosed each year. And it is clear that cancer will overtake cardiovascular disease as leading causes of death in this century. So there is no doubt that cancer surveillance need to be enhanced in many countries to ensure the appropriate planning, the monitoring, and evaluation. And that means sustainability, which we saw from the previous survey that is one of the main problems, sustainability with adequate appropriate funding. And we need many efforts to modernize the data abstraction and incorporate IT technologies that we have now widely available. None of this would be possible if we don't have the support of many of you, of many persons, and of many organizations that we can see here. Accelerating Cancer Registry Support and Development should be one of the major landmarks for cancer control. Thank you very much.
Thank you, Marianne, for this wealth of information. Can you stop sharing your screen? And it's absolutely amazing. You know, I was there at the first meeting when GICR was conceived. I know people always talk about feasibility and how slow it is, but the amount of work that has been done is absolutely astounding. and sort of makes me feel that anything is possible if that effort was possible. So thank you.
Thank you.
I think we're going to come to our invited presentations, although I think David Jeffrey has been working with us before, so you're kind of part of the group. So David Jeffrey is a Chief Technology and Digital Officer at the MD Anderson Cancer Center in Houston, Texas, and he's building a huge institute on data science, and we've asked him to talk about data for cancer control. So over to you, David.
Thanks, Mary. Can you hear me okay?
Yep.
Can you see my slides as well?
Yep.
Okay, fantastic. So it's a very exciting dialogue this morning already, and I will be sort of resonating on many of the comments in this presentation. The intention is to
Just turn up your volume a little bit more.
turn up my volume louder.
We'll try to turn it up
I'm
too.
pretty loud already here. Maybe the volume on your side we could turn up a little more, Mary. Avi, can you hear me okay? Yeah, okay.
Yeah, keep going.
Okay, perfect. So what I'm going to do is describe some of the work and thinking that we've been going through around the process by which we bring data together to respond to the demand of burden in the context of cancer. And this work has been informed by great conversations, Dr. Chung here at MD Anderson, Dr. Gospodarowicz, but also is a bit of a preview to the kind of work that's going on as part of the Lancet Commission on Cancer and Health Systems, in which I co-chair Working Group 5 with Dr. Gospodarowicz. And there's been just a really fantastic dialogue, including with Elizabeth and Marion and many others, trying to understand moving forward into the future, how we sort of design our systems to respond to the burden of cancer. And I'm going to take on a little bit of a journey here to start with, and it really ties back to some of the comments that came up in the chat earlier on, where it is very clear that there is a wealth of data. We're almost drowning in a wealth of data. It's a paradox, and there's a growing recognition of this sort of emergence of what people call the data economy. The idea that the data is now being thought of as an asset, not just a byproduct of the technologies we use, but rather a pivot towards an understanding of its true value. You know, the collection of information through the process of living, your life record, through own value in this data. And it's not just from an individual perspective, but it's also from an institutional perspective. And this really gets at this push and pull around the governance of data. So while we are immersed in a wealth of data now, we still struggle, as we've heard in the conversations today, to get that in a form that satisfies the demands for the data and for good purpose. And I would argue that we're in a period from a microeconomics of data perspective, now a little risky because I have Avi Goldfarb from the business school here to put up a microeconomics slide, but I'm trying to get you to stretch your minds a little bit. The law of supply and demand is a theory that explains the interaction between sellers of a resource and buyers of a resource. I'm not necessarily talking about selling and buying data. It's more like demand on data and so on and so forth. But the theory really defines a relationship between the generation of that and the consumption of that. And during, the formation of the economy, there are periods where it's really hard for the supply and demand paradigm to get to equilibrium. And we are really in a period where the wealth of data is coming and the demand side they're still learning how to interact. We've had an incredible amount of data dumped into society, and we're still trying to figure that out. And I think this context is where health systems and cancer services are going to collide with that future moving forward. So what does that look like? What is that new way of working? It's not about getting some data and putting it on an FTP site, I suspect. I think it's going to be slightly different. And this just slides on the right, just highlight the idea that we're realizing that the data that we generate through our living, for example, cookies from where we go to on websites, it needs to be something that's better managed, better coordinated. And in the context of cancer services development or the use of data in a cancer care center, we need to evolve the approach we use to manage data. And there are some really interesting emerging paradigms in data management. And the paradigm is that There's like this dependence on data, and growth in data generation is driving innovations in data management. In fact, it's activating the creation of things like chief data officers and organizations that look to steward and coordinate data. It's really kind of a break from the aggregation of data to a data flow paradigm in response to demand. And this paradigm of a data supply chain is now emerging in the literature from the point of view of the steps and life cycle for data that starts with observations or measurement and makes its way all the way through to addressing a demand. When Brian was talking about what people want, what data they need, and the different demands, that really fits wonderfully into this paradigm of a data supply chain. And can we use that language to better coordinate the activities of responding to the burden for cancer? And it really does leverage the maturity of manufacturing supply chain methodologies. And it was just discussed earlier, is if you get going on it, you get better at it. And this is a paradigm that is now coming to data as an economy. Interestingly, AI technologies are highlighting the need for this paradigm. The contextualization of the data for real value and utility, you want to make sure you're putting the right kind of data product into that algorithm if you're going to get the right out. It also is creating some very interesting risks in terms of generation of data or generative tampering. Is that data real, and where did it come from? And there's a nice HBR article by Davenport and et al. That really starts to highlight this. Your data supply chains are probably a mess. Here's how to fix them. There's a nice illustration. And it's really disambiguating the asset of data from the information technology, because everybody wants to run to, if I just had a system, as in I just had the technology, as opposed to I just had an approach, which is this data supply chain thinking. And so data supply chain management is basically focused on data products as the end result of the process. And it can address many issues people have experienced in a variety of industries and were highlighted earlier. It points back to Brian's results as shown in the survey that different people need different products to do their job. And shaping that and working on that and crafting that is a maturation reflection of the supply chain. It puts equal emphasis on all phases of data management, from collection to organization to consumption of data products. And we can then start to refine and measure the supply chain performance, things like quality, frequency, provenance, and traceability of the product in terms of its value. Now, I'm not going to go through all of these, but they provide a really nice framework to establish a data supply chain. And as I was listening to Marion and the work of the GICR and how the cancer registry is, in fact, probably one of the earliest data supply chains ever generated across a globe to feed data. And it starts with the establishment of management responsibilities, sort of building that capacity to start to collect that data, curate, move it to the next step, and be consumed ultimately as a data product in various settings. I'm not going to take you through all these, but the key is this is not a technology conversation. It is about a demand-driven maturation conversation. It's appreciating value of data for purpose, and it's key to stimulate investment in data supply maturity. So refining what we need, getting that demand, generating that pull is key. Okay, now I'm going to put it in two different contexts. The first context is the healthcare context, where we all, Avi, we are all very excited about AI and machine learning and all the things it can do. There's an explosion in data and there's incredible advances in data science. I'm not going to say ChatGPT. What is the path to clinical impact? And we've all seen the hype cycle that we've recognized before. We know now in healthcare that there is an active shift from the power of compute to the importance of the data supply. It's a real maturation and realization that machine learning performance is highly sensitive to training data sets. And the adoption of appropriate use requires matching of algorithm to application and to data supply. Humans have this ability to make some inferences about the quality of the data, and they use that in their decision making. I'm sure Avi will go down this rabbit hole, but computers don't have that inference. They don't have much context to the table. So they can be really blind, and they can generate models that aren't relevant to the context, or the data can shift, as in the data is not stationary, and that can undermine the use of the model. So we need to build these kinds of data supply chains in the context of machine learning and AI, even in the clinical context. We have lots of examples of it during COVID, there were hundreds of AI tools that were built to catch COVID. None of them helped. Many reasons why. One of the reasons argued by Andrew Ng, who is a sort of pioneer in the AI space, is that this idea that if you just aggregate data, you'll answer every question is a flaw, because that aggregated data is not representative of any actual data flow. It's a Franken data set. It's not a real data set of relevance of which you can act against. So we need to think about, is the data of relevance to the context? So we were very excited about this topic here at MD Anderson, and we started to think about the fact that if we want to apply AI and machine learning concepts in the cancer context, we need to enrich the data supply to be a metadata supply chain, something that transports not just the data elements we need for the calculation, but the data elements that also reflect the context of those data elements, where they came from. Are they appropriate for the population? Does it make sense? And so we actually laid out some principles, and we've been using these now to sort of design how we work internally. These principles that we need to have the observations must be in context. We have to capture the metadata around those, has been highlighted in the conversations earlier today. And in fact, if you catch that context, you can analyze that context to study the quality of that observation and make decisions about whether you want to use that observation in the subsequent analysis. This is exactly how human curators work. They go back in, they look at the chart, they see the result, and they conclude based on what's in the chart whether that's an actual valid number. That's how humans work. Machines will mimic humans in this regard. The next one is the provenance and links to insights to observations. Wherever this insight came from, I would like to know the data that contribute to it and where it came from. This is particularly relevant in the context of new generative models. We don't know where the result came from, so can we trust it? And finally, the concept that data governance must be granular and consistent with the needs of demand allow us to get through that idea of what data can I use for what purpose. And remarkably, and somewhat paradoxically, more governance may release more data because there's clarity on the control of that data. So these principles we've articulated for what's needed in terms of the application of AI in the context of cancer. And fully leveraging new computational capacity relies on increasing the maturity of our data supply chains. And transporting metadata, we argue, is a measure of data supply chain maturity. So we can see within organizations, we're going to want to go this way. We're going to want to have the capacity in our little bowls to understand the flow of data so we can do AI and ML thinking. Simultaneously, we're going to want to go and have that data flow into a broader cancer services control paradigm, because these systems shouldn't be separate, as highlighted in conversations earlier today about why can't we use the stuff that's in the record to inform us better? Why are we doing this as two separate components? So what's the bigger picture? I'm not going to dwell on the scale of the problem of cancer moving forward and our challenges with getting there, but clearly data and making compelling cases for interventions is part of it. We could argue that the current way that we measure burden, described here by Chris Wild in detail, is going to have to be what we want to address as we seek to design cancer services. But the measurement of burden today is largely in the frame and context of the registry, but there are broader definitions, and even the registries are getting pushed in the conversation with Marian and others, pushed to bring more data forward to inform that burden. I think critically what we're going to see also are new data supply chains, and I'll talk about this in a second, where we want to measure less traditional paradigms, like lived experience, measuring burden enabled through connectivity with individuals, as highlighted in these stories. And I think that's going to be part about how we activate urgent response. We all are aware of the complex measures of burden of illness, everything from an understanding of the economic components to the quality of life components, the epidemiological elements of this in terms of prevention and avoidance of risk. These are all measures of societal individual burden. And then also further dimensions in terms of measuring burden and its complexity. But a complex burden of illness needs a complex solution to respond. Now we have the Global Burden of Disease Studies, launched, that one was published in 2010, Chris Murray and company. But if you read through those, there's this commentary, which I think is really, really interesting, is that, this is Richard Horton's comment, that Instead of GBD being a single event every few years, it needs to evolve into a continuous process of reviewing, updating data as new and more reliable information and methods comes forward. And another comment by Margaret Chan from the WHO at the time, we need to convene a dialogue around how we change the way data flows. Real need to close the data gaps, especially because it's not reflecting the challenges in low and middle income countries. And this was highlighted by comments by Marianne as well. So how do we track this? How do we get transparency? And Chris made a comment in an interview when GBD 2010 came out on the fact that as more data are made available and collected, the task of tracing global health epidemiology is much more challenging than when there was little data available. So here we are in a wealth, yet it's hard to transport that forward. The WHO just announced a new initiative, Health Inequality Data Repository, April 20th, 2023. And I'd encourage you to take a look at this. And there's a really interesting interview, and one of the analysts who was involved is shown in the picture right here. And she described what she had to do to start to put this data together. Get PDFs, run them through NLP, extract information. It's an exhaustive process, remarkably exhaustive, given the state of technological capacity we have. And this is April 20th, 2023. And they highlighted the fact there's nearly 11 million data points, consists of 59 data sets from over 15 countries, and the data goes back to about 1980. So I'm being generous in saying that this represents 0.0014 data points per human alive today. Now that is such a contrast to the fact that we currently generate 650 million tweets a day. We have over 100 million eye watches on humans on the planet in 2020 streaming data. And there are estimates that nearly 30% of the world's data is generated by healthcare. And so this incredibly stark contrast between the collection through the process of care, the growing engagement of measurement outside the healthcare domain, and the challenge we have to get data through to effectively inform the development of new services. And some argue, this is an old article, 2018, it seems old, is that we really need to have a paradigm where this kind of data is flowing more rigorously to inform services. And I'm not going to dwell on this, but it is an approach that's clearly coming. And if it doesn't come from healthcare, it may come from other domains, because the rate of data supply and maturity in those industries is going very, very quickly. So as part of the Lancet Commission on Cancer and Health Systems, we've been looking at what does the future look like? And we very much believe, and are hoping to validate through our work, that a computationally enabled predictive paradigm will guide investment. However, it does need a robust data supply chain. The idea that we can characterize populations and their burdens, services, and environmental factors, use these and their connectivity in terms of the interaction between existing interventions and population to simulate interventions, develop digital models or twins of populations, and then identify what the appropriate intervention is, could inform real interventions, whether it's financial, policy, technological, societal, and then apply those back in this really true paradigm of a learning health system, is one of the things that we're exploring. What's the possibility we could pursue this moving forward? And just looking at the feasibility of this approach, how do we turn these data-driven models into actual action? How does it convert to policy? And there are other elements that become interesting, for example, integration of other global predictions like climate change, better approaches than best by paradigm, and of course, broader learning health system design. Now, one of the things that we draw on from this is some of the work we did in the past on the Global Task Force for Radiotherapy for Cancer Control, where we really look globally at the burden and demand is measured using GlobalCan data, measures of outputs of current intervention paradigms, looked at details of cost and activity, and we're able to forecast based on an investment framework what the benefit would be for society. We believe that this paradigm will continue to grow moving forward as a method to drive investment in healthcare systems. There is substantial prediction of benefit associated with this kind of investment by 2035. We are nowhere along on that journey at this point in time, but illustrating the potential capacity. So the value of prediction to drive intervention. Now, these results have been used to motivate investment in radiotherapy technologies, to stimulate the development of novel technologies that address shortfall, for example, in talent, and to decrease costs moving forward. It also demonstrates the potential for broader modeling efforts. We're seeing this being applied in other domains in cancer and outside of cancer, but it really does highlight the limitations in the data used to inform the nature of burden, but even the existing state of cancer services. So we understand the state of cancer burden at some level, great project progress on registries as a paradigm, as a data supply paradigm, but at the same time, bringing up and shoring up the corresponding cancer services that are already there if we're going to model against is something that is seen as a weakness. So we've started this journey, and it's quite fun actually, with a number of early career researchers and a number of not so early career researchers who are helping us to sort of ask the question, what can be learned by bringing the data supply chain paradigm to respond to cancer burden? How do we think about the collection of information, unbiased measures of cancer burden, interventions, outcomes, and impact on society? How are they connected? Is there consistency? How does that approach work? How do we manage the access and governance to that data? And is it demand for purpose? What are the data products that people are asking for? And through this process, we can actually have insight development, decide on interventions, whether it's personal or at a population scale, and use that to drive action. So we're studying existing data supply chains to understand, are there common metaphors and paradigms across these? Are there common issues across these? And if we do that, can we start to work more cooperatively across industries and across agendas to lower the burden of collecting this information and drive up quality, effectively mature a data supply chain? So we're looking at a variety of them. We've had great conversations with the teams in the registries to understand what is probably the most mature data supply chain in healthcare in the world. It operates globally. It has stages. There's a quality assurance activity. There's a connectivity aspect of it. But it very much is driven by local champions. What's the vulnerability to that data supply chain? We're also looking at the genomics data supply chain, often quite different than the registry data supply chain. The real world data, when I say real world data, I mean this growing interest in the commercial practice of capturing data and using it, curating it, such as in the context of Flatiron Health. And very interestingly, we see a lived experience burden. This is collaboration with another working group in the commission, working group 1 that looks at burden, is to understand how new paradigms, maybe through connected digital platforms where people are sharing their experience in burden, would also be used to inform cancer services. So we're on a journey now, looking at these and looking to see whether or not this framework would apply. We want to answer the question, what are successful data supply chains that are currently operating to inform cancer service design and development? What is their maturity level? Is there a maturity level measure? And what innovations are emerging in data governance and curation that we could leverage to facilitate a better description of burden globally? So in summary, there's rapid multiple order of magnitude changes in digitalization and computing are creating the emergent data economy. We see it around us. And this is a pan-industry transformation that's driving technology and expectations. The adaptation of the supply chain maturity methods to the data economy can be informative as we work to use data to inform decision-making and intervention. In conversations I've had with industry and academic partners, just talking about a reframing of a cooperative activity with common elements associated with the data supply chain has been very informative so far. We'll see whether or not this analysis will give clear insights moving forward. Interestingly, in the clinical context, the same issues exist. The performance and utility of machine learning technologies depend on rich contextualizing metadata that is curated and managed. And in the health system context, opportunities to re-examine our approach to data management to increase quality and efficiency. And these don't have to be done in isolation from other emerging data supply chains related to other services that are consumed by society. So I'm going to stop there and pass it back to you, Mary, to introduce Avi for his talk before we go to the panel. Thank you, everybody, for your attention.
Thank you, David. Maybe while Avi is talking, you can check your microphone because we've turned up the volume here quite hard and it's quite hard to hear you. You seem like you're halfway to the moon somewhere, further than MD Anderson. So thank you very much. And I'd like to introduce Abby Goldfarb, who, as I said, is the Rotman Chair in Artificial Intelligence and Healthcare and a professor of marketing at the Rotman School of Management at the University of Toronto. Abby is also a chief data scientist at the Creative Destruction Lab and Creative Destruction Lab Rapid Screening Consortium, and a faculty affiliate to the Vector Institute and the Schwartz-Reisman Institute for Technology and Society, and a research associate at the National Bureau of Economic Research. And his research focuses on the opportunities and challenges of digital economy. I've heard Abby before when he lectured to us in Toronto, but I have to say that he published a number of books, and his most recent book, Power and Prediction, the Disruptive Economics of Artificial Intelligence, was particularly interesting to me. I must admit, I haven't read yet the full book, but I've heard a number of interviews, and the way that you connected the prediction to decision-making, and especially the reference of healthcare, was very interesting and stimulating. So we're looking forward to your talk and then following panel discussion. So welcome and thank you for participating.
Okay, thanks so much. I'm going to share my screen. Okay, there are the books. And just get you guys.
Yeah, we can see it.
Okay, so there is no shortage of hype these days around artificial intelligence. For some of us, we've been thinking AI has been exciting for a while, but for most of the world, it's really just been in the last few months that they've recognized how useful these technologies are through generative tools, mostly ChatGPT and some others. And we are seeing hype on the positive side, like it's going to become a multi-trillion-dollar industry. And we've seen hype on the negative side, as in, I welcome our future AI overlords. Daniel Kahneman, a couple of years ago, the only psychologist to win the Nobel Prize in economics, said, clearly AI is going to win, and how people adjust is a fascinating problem. It's a fascinating problem if you've already won the Nobel Prize. For most of us, it's not a fascinating problem, it's a terrifying problem, which is, what does it mean for me if the machine's intelligent broadly, or if the machine does the particular kind of intelligence that defines my career? Now, that idea of a machine being intelligent broadly, like an artificial general intelligence, that's not the technology we're talking about in 2023. If you go back to the 1960s, AI researchers have said artificial general intelligence is 20 to 50 years away. A few years ago, the leading researchers said 20 to 50 years away. In the last few months, there's been some acceleration of that timeline, but this is not the technology that's happening on the ground. This is not the technology we're talking about today. What we're talking about today is prediction technology. In the statistical sense, just like David just said, using information you have to generate information you don't have. That's it. Nothing more exciting than computational statistics. Had we called our book Prediction Machines: The Simple Economics of Computational Stats, no one would have bought it. And more generally, there is a sense in the community that calling it AI makes everybody all excited about it. But it's not that. It's computational stats, it's prediction technology. And about 5 years ago, what we started to experience was a drop in the cost of prediction. Prediction got better, faster, and cheaper. And as an economist, I know what happens when something gets cheap. People buy it more. For those of you who took an econ class, I don't know if you did way back when, the very first thing you learn in your very first class, that is about demand curves. So when prices fall, people buy more of things. If coffee suddenly becomes a lot cheaper, people are going to buy a lot more coffee. If prediction suddenly gets a lot cheaper, then people are going to use a lot more machine prediction. And that's exactly what we've seen. We've seen uses of machine prediction in good old-fashioned prediction problems that we've known were prediction problems for a long time. Like you walk into a bank and you want a loan, and the bank has to predict whether you're going to pay back your loan. That is perhaps the oldest prediction problem in business. And increasingly, we're using AI, we're using machine learning tools to predict whether you're going to pay them back. The insurance industry, they're in the business of prediction. That's what they do. They price risk. And increasingly, they're using these machine learning tools. They're using AI, prediction machines, to figure out whether you're going to pay, whether you're going to make a claim and how much that claim is going to be. But as machine prediction is getting cheaper, we're starting to realize that some things we didn't think of as machine prediction can be reframed as prediction problems, like image recognition. Image recognition is increasingly solved with prediction. How do you recognize an image of a cat on YouTube? How do you recognize a familiar face? Your eyes take in these light signals and they fill in the missing information of a label and a context. Turns out that can be solved with machine prediction. And most relevant to this audience, medical diagnosis is prediction. What do you do when you diagnose? You take in data about symptoms and you fill in the missing information of the cause of those symptoms. It is prediction. If you asked most doctors 20 years ago, or even 10 years ago, or perhaps even today, if what they do in diagnosis is prediction, they would have no idea what you're talking about. But nevertheless, that's what it is. That's what, as machine prediction is getting cheaper and cheaper and cheaper and cheaper, we're recognizing new applications of prediction, including at the center, diagnosis. The tools that everybody's been excited about over the past few months are also prediction tools. OpenAI takes in data about the corpus of stuff happening on the internet, like takes in data, or not happening now, but in the past, millions and millions of documents, billions or trillions of words. And then in response to a query, it predicts what set of words is the appropriate set of words given that query. It's nothing more than a prediction machine. It's an incredible prediction machine, ChatGPT, but it's a prediction machine. DALL-E and Stable Diffusion, same kind of idea. Turns out, as prediction got cheaper, not just image recognition, but image generation could be solved by prediction. You ask DALL-E for an image of an astronaut on a horse in the style of Andy Warhol, and it will give you that. It's not that this was in its data set, but it had data on people on horses. It had data on what the style of Andy Warhol meant, and it had data on astronauts. And it combined those to project this kind of an image. It's a prediction machine, but as prediction has gotten cheaper, as machine prediction has gotten cheaper, we can identify things that we never might have imagined can be reframed as prediction. Prediction matters for one reason and one reason only. Prediction helps us make better decisions. A prediction in and of itself is useless. We've had, startups come into the creative destruction lab, say they built these predictions, and we say what the prediction's for, and they say predictions for giving our customers insights. And we know when they say that, it means they have no idea which decisions their prediction is going to support. And the mentors in the lab very quickly turn away and lose interest. Predictions are useful because they help you make better decisions. And the key is to understand which decisions your predictions that you're building are going to support. Because decision-making is the big deal. Prediction is not the big deal. Decision-making is the big deal. Prediction supports decision-making. But prediction isn't decision-making. And that's where the opportunity lies, right? What's left for us humans? If clearly the machines are going to win and how human adjusts are a fascinating problem, as Professor Kahneman said a couple of years ago. Well, today's AI is going to win in prediction. And there's still plenty left for humans, even when the machine is doing the vast majority of those predictions. Right? Not the insights. If it's providing insights, it's telling you it doesn't know, then you don't know what to do with it. Not general insights, but specific predictions being supported. But a key thing to remember is decisions don't occur in isolation. Decisions are coordinated. And so in order to understand the consequences of your machine predictions, And to make your decisions work and work at scale, you have this challenge in getting all the decisions within your organization to work together. So what we've seen in terms of AI challenges and AI adoption are these challenges in symbiosis, effectively, which is you might have an amazing diagnostic tool, but if no one else in the organization is changing how they operate, it doesn't matter if you have an amazing diagnostic tool. Or if you're diagnosing a disease that doesn't have a good treatment, who cares? What you need is not just a great diagnosis tool, but you need a workflow that accounts for the new kinds of diagnoses you might be able to have. If you can detect things early, do you have treatments for early detection? If you can detect particular subvariants of particular diseases, do you have treatments for those subvariants? And if the answer is no, the prediction machine itself won't be that useful. So fundamentally, it's not just the prediction supporting one decision, and you got to think through the various other decisions. But what we have seen as predictions gotten cheaper is a handful of industries are imagining this vision of what that future looks like, and they're embracing this hype. AI is the new electricity. And the way you might imagine that is turning a dial. Okay, so your predictions are okay now, and they get better and better and better and better over time. And at some point, they're going to get good enough, that dial is going to get high enough that you can do things entirely differently. It's not about the supporting the decisions in your existing workflow, but you're now thinking about coordinating across and creating new kinds of workflows. So an example that people tend to be familiar with is Amazon. So Amazon makes these predictions about what you're going to buy. And those predictions are amazing. Their recommendation engine is right something like 5% of the time. So they have hundreds of millions of items in their catalog, and for every 20 they recommend to you, you buy one. That is an amazing feat of engineering, of data science. But it hasn't changed the way Amazon really operates. Amazon remains fundamentally a catalog company. You go to their online catalog, you say what you want, you listen to the recommendation or not, they send that information to the warehouse, and they ship it to your door. 20 years ago, the workflow at Amazon would have been the same, but instead of a recommendation engine, they would have just told everybody to divide the Da Vinci Code. That was the most popular product in Amazon. Everybody pretty much got the same recommendation. But after that, the workflow is exactly the same today in some broad sense than it was then in terms of the ordering process. Now, imagine you turn the dial. So instead of 5%, they're 10, 20, 30, 50, 70% accurate. At some point, they're going to realize that they can do things differently. At some point, they're going to be confident enough in what you want that they'll just ship the stuff to your door. And every morning you'll open up to a box at your door with stuff from Amazon. And you'll take some of it and you'll leave some of it, but that'll be okay. They'll get a big enough share of your wallet that they'll be perfectly happy to build an infrastructure for returns to deal with it. Rather than you shop and then they ship, they'll ship to you and then you shop at your door. Now, let's be clear. We have no idea if this is going to happen, but we do know that they've thought about it pretty deeply. Here's a patent for anticipatory packet shipping from Amazon. This using better and better prediction to transform the business is something they have thought about. But then look a little bit closer and you see they thought about it 10 years ago and it still hasn't happened. So how can that make sense? What went wrong? And in industry, the vast majority of companies that do spend on AI, which represent a tiny fraction of the overall US economy, most of them say it hasn't been worth it. We spent this money on AI, we spent this money on data science, and we've got a whole lot of nothing. How does that make sense? How can we reconcile that with this statement and this excitement that AI is the new electricity? Well, maybe you need to think a little bit more about electricity. So It was clear in the 1880s that electricity was going to be a big deal. Edison's patent was 1880. Tesla's patent for the alternating current electric motor was 1890. In that decade, if you were paying attention, you would have realized that electricity was going to transform the way we lived and the way we worked. But it wasn't until the 1920s that half of households and half of factories in the US, the leading country in the world, were electrified. It took 40 years from the people paying attention to see how this was going to transform the world till it affected most people at home and at work. What happened? What happened is related to that challenge on decisions don't occur in isolation. What happened was the old way of doing things wasn't conducive to the new tool. So this is what a factory might have looked like in the 1880s. There's a steam engine at the center of the factory, and you can see that all the machines are connected by these belts to that central steam engine. And for those of you who remember your high school physics, energy dissipates with distance. And so the way they organized the factory was to have the most power-hungry machines as close as possible to the steam engine. The factory logic was determined by the power needs of the machines. And so the workflow was determined by the power needs of the machines. And you moved sort of the pieces that you were building back and forth all over the factory without sort of a particular logic based on the power needs and not on the production process. And what happened when electricity came along is they said, a handful of factories said, well, this is going to be a little bit cheaper. And so they took out their steam engine, they dropped in an electric motor in the exact same place and kept the rest of the workflow the same. But for most factories, saving a little bit, 5, 10, 15% on their energy costs wasn't enough to justify the expense of laying down wires, figuring out electricity distribution, entirely new machines that were electric-based, etc. It wasn't worth the bother. And so even by 1900, only 5% of US factories were electrified. But around 1900, things started to change. Up until 1900, everybody had been doing what we call point solutions. They look at the existing workflow, they find places where you can replace a new tool replace the old tool with a new tool and keep the workflow the same. Around 1900, people realized they could build different kinds of factories. That because of electricity, the machines were now decoupled from the power source. And you could have inputs come in one end and outputs come out the other in a modular, structured, organized production. The 20th century, quintessential 20th century factory that we think of, suburban, huge spaces with an assembly line moving from one end to the other, that is a consequence of electricity. But it required a reimagining of what the factory meant. It was an entirely new system. And once they figured out that entirely new system, that's when we saw a change in trajectory of adoption. And over the next few years, an acceleration in factory adoption of mechanical drives and other things. With AI, we are in the 1890s. We have figured out that this technology is a big deal, but all we're doing are these point solutions. We're looking at our existing workflows and figuring out what we can do a little bit better by replacing some existing human prediction process with a machine prediction process. So the last question is, what does this mean for your particular context, your particular industry, and how do we start to reimagine what that better workflow might look like? Right? We say, okay, we have these point solutions. Point solutions generally aren't worth it. Doing what you've always done a little bit better is rarely worth the bother of building the data systems, the supply chain, et cetera, that David was just talking about. Okay. You have to really see some end value. And big picture end value is going to be more than efficiencies. That's going to be about reimagining what you do in various ways. Often that reimagining starts with where you fail. So think about the ways that you fail to deliver value, and think about how much of your processes are addressing those failures. easiest place to see this is in airports. This is Seoul Incheon Airport. It is often voted the best airport in the world. What Seoul and Singapore and Beijing and these other top multi-billion-dollar structures have in common are great restaurants, great shopping, natural light, big spaces, greenery. You might see a waterfall or fantastic public sculpture. These are beautiful buildings and places that maybe aren't so bad to spend time in. But all of you would rather fly through this airport. This airport is the private terminal at Boston Logan. This is how the super rich fly. If you are a billionaire, you don't fly through $1 billion airport. You fly through an airport that's basically a shed that probably costs a few $100,000, right? It's some windows, some seating, there's a magazine rack, but if you look carefully, it's all the same magazine. Now, how does that make sense? How come the ultimate in airport experience looks like this, and the rest of us get to fly through these beautiful multi-billion-dollar structures? Well, reality is no one wants to spend time at an airport. The reason they have these multi-billion-dollar structures is because they fail to deliver on their mission to ensure smooth air transportation. That's Seoul Incheon's mission, to ensure smooth air transportation. But so much of what they do is compensating their customers for the fact that they fail. What's smooth air transportation? It's what happens at this private terminal. They arrive at the airport, they walk through the airport, they walk on the plane, and the plane takes off. They don't spend any time at the airport. Now, in every industry, you can imagine all these various ways that you fail to deliver on your mission. Now, this is not an example how doctors fail, but this is an imaginary scenario. Okay, so imagine you go to your doctor. We'll see. You'll see why this is relevant in a second. I just, in a medical audience, I just have to set that up first. Okay. Imagine you go to your doctor and your doctor says, well, looked at your blood work, seen your symptoms, and there's a 5% chance something catastrophic is going to happen to your health over the next year. And if that happens, we'll give you $500,000. Okay, see you next year. That's not the way it's supposed to work. Once you diagnose me with some high risk, you're supposed to provide some kind of treatment plan to reduce that risk. Now, luckily, as far as I know, that is not how the medical system works, but it is how insurance works, right? Your insurance company has all this amazing data about your house, right? They might have satellite, they have inspections, they have all this great data about your house. And with that data, they provide a prediction that something catastrophic is going to happen to your house. And underlying that prediction is data about why something catastrophic might happen to your house. But they don't tell you that. They just say, look, there's a 5% chance something catastrophic is going to happen to your house over the next year. If that happens, we'll give you some money. And in the process, we say we're giving you peace of mind against catastrophic loss. That's not what they're doing. What they're, maybe it's better than the alternative, but real peace of mind would be to do what you guys do, what doctors do, which is to say, here's the problem, and here's how we're going to help you reduce that risk. And it turns out the tools are available in insurance. It's not that hard to put in a sensor on your pipes that are going to shut down your pipes if they're going to leak. And if you're the kind of person who has a house where your insurance is expensive because of the high potential of leaky pipes, it's very much worth it for you and the insurance company to provide that sensor. But they don't. And we've been working with an insurance company, one of the big US insurance companies, to try to make this happen. And it's been really hard. And it hasn't been hard on the data science side. There's been some challenges there, but that's not the fundamental problem. They can predict at the sub-para level what might go wrong. The hard part is the center of control and power in insurance companies is underwriting. They're the people who price the risk. They're the statisticians. And they control the data. And largely they control the regulatory relationships and decisions. But what I just described is about behavioral change. And that's not about underwriting, that's about marketing. But in most insurance companies, marketing aren't at the center of their decisions. And what this would mean is the chief marketing officer is now going to be at par with the chief underwriting officer. There's going to be a change in the power structure of the company, and they got to get along. And that's just really hard. Underwriting now has to give marketing access to their data. And there's another challenge, which is an insurance company, the center of marketing isn't behavioral change, it's sales. And what does sales care about? They care about commissions. And so the whole idea of a new way of doing things that's going to reduce prices by reducing risk is explicitly against the incentive set up in the organization. So in order to build this system where they can help you reduce risk by giving you sensors for leaky pipes or electrical fires or telling you the issue is with your roof, they need to change the org structure, move power away from the people who are actually doing the predictions to other parts of the organization. And that's what makes it so hard. This symbiosis, this coordination of decision-making is what makes it so hard to implement system-level change to take advantage of what prediction machines can do. I'll tell you one last story quickly. Okay, so this is a sailboat. Hopefully you recognized it. It's a particular special sailboat. It's the sailboat that won the first America's Cup race way back in the 19th century. Okay. There's been a ton of innovation in sailboats since the 19th century. And so this is the sailboat that won the most recent race. It barely looks like a sailboat. Okay. For most of the 20th century, innovation happened in wind tunnels. They could sort of simulate the wind and the wind in particular through a wind tunnel to figure out how to design sails. Then about 30 years ago, they realized we understand fluid dynamics well enough that we can simulate in a computer and run all sorts of simulations about different boat designs. The problem was you don't win a race with a good boat design. You win a race with a good boat design and a good sailor. And there was almost no innovation in sailing over that time period because sailing innovation happened in human speed at human time. What the team that won the most recent race realized is there's a new way to think about coordinating to create an entirely new kind of sailing strategy, right? So you need a great boat and a great sailor. That requires coordination. That sounds like system level change, symbiosis. What they realized is they could start simulating the sailor and the boat design with an AI. And in this process of what they called a digital twin, you might think of just a simulation, they could reimagine the boat and the sailing strategy so that the AI developed new strategies for new kinds of boats. And they brought it into the water and it worked and they won. It's a statement that coordination can be overcome with careful planning and in some contexts, simulating how things will all play out. So in healthcare, in cancer care, we're probably in the 1890s. We see that this technology is so exciting, and where it is overwhelmingly being dropped is into existing workflows. And that's leading to some benefits, but not as much as you might expect given the hype. And what we need to think through is what is that new organization, that reimagining of care look like to take advantage of better prediction to coordinate with all the other relevant decisions within the workflow. Thanks. And I think it's time for our panel.
Thanks, Avi. That was great. Mary, you want me to go ahead, Mary?
Over to you, David, to start the panel.
Okay, it's great. Great presentation, Avi. Really enjoyed it. And I'm just seeing Ali Berlin. Could you join us on camera? Fantastic. Great to have Ali here. And Marion, I think, is going to join us as well.
We should introduce the
I will.
Ali Berlin is Associate Professor of Radiation Oncology at the University of Toronto and a Medical Director of Cancer Digital Intelligence Program at Princess Margaret Cancer Center. And I also believe, Abby, that he's working with you in Creative Destruction Lab. So over to the panel.
Thanks, Mary. Yeah, fantastic set of presentations. Marion, really enjoyed your overview and highlighting the growth. Avi, discussion and presentation on prediction and the paradigm that you introduced is very exciting. And Ali, I've enjoyed working with you. I've seen fantastic work that you've done in advancing virtual care at Princess Margaret and the adoption of technology and driving things forward there. So maybe we'll give Ali a chance just to provide a little commentary at the beginning and let him make some comments first. I always think it's better to have everybody on the panel to have their voice activated. So Ali, I'm going to put you on the spot. Tell us a little bit what you do and what your thoughts are on the presentations this morning.
Yeah, so I really enjoy the presentations today. The fact that I like the most is that David spoke about economy and Avi spoke about physics. So it was remarkable. So we deployed a technology around prediction, which was an AI-based method for developing radiotherapy plans. And it's very interesting because lots of the things that Avi mentioned do resonate very strongly, because with this other job on deploying virtual care, there's a lot of emphasis in workflow and mapping workflows, understanding, know where things can work, where they don't work, what the upstream and downstream implications when you perturb the environment with a new technology. So the bottom line of deploying AI for predicting a radiotherapy plan, the way we framed the problem was exactly that, we're going to use a technology to predict a plan based on historical plans that were done for patients that had prostate cancer, and how can we use that to predict a plan that could be judged favorably by the experts. So the emphasis was in the judgment and the humans interacting with that output of that prediction. But the tension comes, at least in healthcare, is that you would like to reshape the workflow from the get-go. But one is very difficult because you have to gain trust from the users, and the performance of Amazon of 5%, if it improves to 6%, is amazing, and the revenue will skyrocket just with that 1%. But the failure in healthcare sometimes is too expensive to allow such performance. So we can throw an algorithm that performs at certain level, and we can discuss where that level is. But the problem is that also in healthcare, you need to demonstrate the value of it. So we did demonstrate the value of gaining and cutting the planning process by like 60%, having a technology that you can scale and replicate across other centers where you can share expertise. So there's a lot of value there. But the way we have, at least the mindset we have in healthcare, and this comes even for clinical trials, is that you don't perturb the environment. You put a new method, a new approach, a new drug, and then you evaluate the results. If that works, then you adopt it into the use. So this kind of development deploy approach is very challenging in healthcare. I haven't wrapped my head around, so I'm leaving more with questions and things. But I think we do have experience deploying technology, enormous gains when you do it. But there's this tension between evaluating, doing it without altering and not failing in healthcare, that perhaps other industries have more luxury, at least when these technologies are reaching patient care. And that's kind of where I believe most of the tension and the lag comes in the healthcare environment. I have other thoughts, but I think I can.
That's great, Ali. I mean, I think that really strikes at the conversation that Avi formulated for us, is this sort of what's the time constants of change that are constraining us, and your example of dropping in a technology, I used to call it spot welding activities all over the place. But then I always wonder, if you just spot weld enough, the system's going to eventually restructure. But Avi, have you thought about healthcare specifically in terms of the constraints and the restructuring? The need to build clinical evidence is one that we often don't have in other industries.
Yeah, so there's three core challenges in healthcare. They're all interrelated. The first one is that the stakes are high. Okay, so look, what industry has seen the most transformation in the workflow because of prediction technology? It's advertising. Because you know what? If you see the wrong ad, who cares? Okay, it's a pretty low stakes industry, and they could transform, and who really cares? The stakes are high in healthcare. Messing up is a big deal, and so that's a real barrier. And the other two are in many ways consequences of the fact that the stakes are so high, which is one, there's a regulatory environment where it's not easy to deploy new processes and without lots of testing and evidence. That's a good thing. There's changes necessary to the regulatory environment to deal with the fact that things are software and there's software updates, and but we're moving in the right direction there. And the other, which might be a little more controversial in this audience, is so many medical decisions are controlled by doctors. Okay, and there's good reasons for that. But this is much of the opportunity in this technology is about changing what doctors do. And it's a lot easier to change what people who aren't the core decision makers and in leadership positions are doing than what they are doing. So than others. So like I started to look into radiology and how AI was changing radiology about 5 years ago. Okay, like right after Hinton said we should stop training radiologists now. And at that time, when I was really digging into it, AI had already transformed radiology, because you guys, like, you'd talk into a microphone, and there used to be a team of humans who transcribed it, and now that's done with Dragon. And so that was an easy thing to do within the existing workflow, because the core decision makers, the people at the center of power in the organization, weren't disrupted. It was other people. As we start thinking through diagnosis AIs, what does that, there's this big question about what does it mean for the doctors, and how we're going to create physician acceptance of a technology that changes, that ends up being a lot of work for physicians and creates risk to their income.
No, that's great. Great point. The three elements: the stakes are high, it's a regulatory environment, and the key decision maker is a human that is trained and trusted. I was going to ask you about trust. Ali, you wanted to say something. I saw you put up your head in a very traditional way.
I want to say, if there's perhaps a fourth element, I don't know, Avi, what you would argue back here, but I think you talked a lot about investment. I would argue that in healthcare, in the majority of settings, perhaps some jurisdictions where they have some, let's say, more quantifiable and measurable output of their activity, and like revenue and stuff like that, we're more on the expenditure mindset. Like, we spend on electronic medical records because they are supposed to make things better, but I don't think there's a true quantification of return of investment and value generation by those activities. So I think healthcare, I don't know in the macro, but perhaps more towards the micro, is a very non-ROI kind of driven type of decision making. Would you agree or disagree with?
I think it varies by system and country and even hospital. But if the payoff is big enough, so you talk about ROI, but even in patient health or whatever else, like industry by industry, if the payoff is big enough, and healthcare is no different here, you should expect the investments in the technology. So I see that as a barrier, but in the way I think about it is once you've figured out a system level change that's going to massively improve things, whether it's for patients or in the bottom line, then we'll want to spend the money to make it happen and adopt. So maybe a version of the barrier you just described is figuring out what that massive opportunity even looks like.
Very good. I want to spend a little more time on this, decision-making paradigm a bit, and then I want to roll out to kind of the system side of the whole thing, and go back to a question that was asked about Brian on AI and data and so on. But a little more on this sort of decision-making. The trust element, I think, is a big part of this. And Avi, when you talk about prediction, and then Ali, when you worked with those systems that generated plans, like, who do you trust the dosimetrist, Ali, or do you trust the algorithm in that, or what? How do we see trust? And because a prediction, if it's 100% going to be right, then maybe you're good. But how does that trust element get reinforced as we displace humans potentially in this?
So I can tell you from our experience, there's a lot of anecdotes in the journey, but there's two main key probably messages. So one is that the planning is usually done by a therapist or someone trained on generating radiotherapy plans. We put the AI system under their control. So the fear of replacement and stuff wasn't quite there because they were generating their plans, and at the same time they were generating the AI plans and showing both to the clinicians. So that was first element that I think that allowed us to deploy. The second one was that we said at the end of the day, there's a clinical judgment in determining if that plan is appropriate, ideal, or the best plan, and that was unchanged. So we even had discussion if this should be a clinical trial, which is very complex to do, how you consent patients on something they don't really understand, or this was a quality improvement initiative, because at the end of the day, you don't care how the plan is generated if the evaluation metrics are there. So I don't care if the planner is using the right or the left hand to grab the mouse of the computer. What I care is about the end product. And if that evaluation remained the same, which was the case, then the source of the plan was less relevant. So we de-emphasize the source of the plan because that judgment element and that clinical kind of decision goes back to Avi's point that the decision makers weren't perturbed by this. And that is perhaps what allows us to introduce it to the clinic. And now it's our standard of care. Every patient coming through the doors at Princess Margaret gets an AI-based planning for prostate cancer. So I think those two elements were that the people who may have been threatened had some degree of control, and the decision at the end of the day remained unaltered, independent of the source of the plan. So that's how we think trust was gained pretty rapidly on this.
Yeah, so you get an efficiency advantage. I mean, we're seeing the same thing on these large language models where a lot of the vendors are positioning them as a co-pilot paradigm. In other words, they work cooperatively with the human. And I think that's where the sort of like a bridging trust architecture formulates there to get the efficiency advantage, but not have to question the trust side. Okay, I'm going to shift topic a little bit here. And there are a lot of questions. I know, Avi, I don't think you could join us then. There are presentations on the registry architectures. It was a fantastic presentation we had earlier, and Marion's description of how we're going to support these systems. So rather than like decision, there are a lot of other steps where AI and machine learning could affect. So Marion, maybe you want to comment around what you're seeing globally in the sort of data supply chain of the cancer registry and the spot welding elements that you're seeing and that can be leveraged. What's real and what's hype? What are you seeing? Please share with us. And you're still muted, by the way.
Okay, thank you. So I'm thinking of the point you're making about the multiple steps when I think about the different settings. So to give an example, and maybe a shift of paradigm that I have learned about recently is one of the cancer registries in my country, in Colombia, is the Cali Cancer Registry. So only some years ago, what they used to do is what registries have been doing in low and middle income always, is they send out a set of registrars to the institutions to copy and according to the definition, say this is a new case, this is not a new case, this is second primary, et cetera, et cetera, et cetera. And they copy that, and that is then fed into the computer. So now they have a team of engineers that through machine learning and through some artificial intelligence, they are scanning the PDFs of the pathology reports, what has allowed them to minimize time, so that they are now, as human decision-making is saying, okay, now we have all this that are highly probably a cancer. Now I need to check whether this is okay. So at the base, that's one step where most of those people sitting here, like Lisbeth and Brian, that step has been done ages, probably not with machine learning, but passively recording of data. They work passively, they don't work actively. So that is one step only in a chain of possible steps where machine learning can help, but it will take a long, long time, because at the basis, what happened is that in our country, they had access to a big database that was national. So they could extract the data, and they had also access and negotiated with the pathologists to have that. So I don't know exactly if maybe Lisbeth also will tell us a little bit of, even if she's not in the panel, but how do you see in a registry, that in an advanced registry, what else besides, of course, you can have now more stage information, but at the end you have to trust what the physician put in the record. So it takes multiple levels of trust, and it takes multiple levels of changing steps when incorporating. And I feel I have very little experience in advanced or in high income countries registries on how they work, but I feel that the gap is very big. So how can more developed, or how can this data supply change, or all these technologies and machine learning, etc., help to accelerate maybe for low and middle income resource countries? That's not so easy, because the information at the base is that sometimes there might not even be the necessary technology to do a complete diagnosis.
Marion, do you have a feel for what it costs us to capture that data and flow it into the consumption of the data, and, for example, in the registries? I think we may have talked about this somewhat in the past, but has anybody ever calculated the cost? I'm just curious.
Yes.
We have an economist here, so a business guy here. Maybe you could lean in on this one.
There are several studies showing costs of what it costs to register a cancer case. And so far, the variability is enormous between, even in the same country, taking different registries, because it depends very much if your personnel needs to go very far away to capture the cases, or if your data flow is passive. So I don't know them now by heart, but we can expand on that in a future conversation. And yeah.
So I'm just wondering, I think from the perspective of how we see this process of data capture to inform insight generation, Avi, do you see something from the point of view, just from a restructuring of industry perspective, that the drop in the cost of these kinds of components from a machine learning perspective, from an AI perspective, I'm just watching and seeing as people are coding on platforms where the prediction, like literally as you're typing code, it's laying tens of lines of code out in front of you, predicting, to your point, Avi, what you want, and it comes out perfectly formatted, some minor corrections. Do you think the connectivity between these platforms will be automated in the future? You'll just be able to say to ChatGPT, connect this to that. I mean, I see a huge acceleration in the development efficiency, the sort of middleware components that these platforms could auto connect depending what you're asking for. What do you think?
Yeah, so 100%. So I think there's going to be, over the next few years, just don't want to make it seem too imminent.
So that was like 1895 or something like that. Does that put us right around 1895?
Yeah. So all these innovations in essentially application layers on top of ChatGPT and the other generative models. And so figuring out, like right now, there's this one interface and it serves a particular purpose. But someone's going to develop an interface that works for exactly what you want in your workflow, that enables the writing tool to connect to the data in your hospital, say, without violating the privacy of your patients and the strategic advantage of your workflows that you have, within your hospital, and provide predictions, write things up, and then so it'll be able to, like, those APIs are going to be built. They're not built yet. There's people building on the privacy side of things already, I know, but industry by industry, we're going to see them happen, and then people are going to have to figure out how to take advantage of that. So, a version of it is, yeah, you can talk to the machine, and literally you might just be able to talk to it without having to look at it at all, and say what you want, and it will provide that. And then, at the end of the, every once in a while you have to check to make sure things are going the way you expect, but nothing more than that.
Yeah, I think I see this for sure. I mean, these sort of business intelligence tools, the classic screen where you go to drop downs, that interface is going to change dramatically. And it's sort of, what do you want? And it'll, the capacity to bring that to you, which I think is very interesting. The question is, how far down the supply chain does that system reach, and to what degree of automation is achieved? It's pretty intriguing. Ali, comment. Then we have some questions in the Q&A we go to.
Yeah, quick comment. I think the other element is like how there was a lot of discussion on how, for example, survival collection or other outcomes. And we still think in a very traditional way, like even internally, you have projects where there is an official cancer registry, which gets data of a live death status with 6 months or a year delay from the official provincial. But once you start having data connected, like, for example, blood work and stuff, someone needs to be alive to go to the lab and have blood work done. So you can infer a lot of outcomes and data points from other data sources, even within the same environment, that we traditionally don't think about that way. So I think it will be more obvious, even like functionality or things like that, when patient, I don't know, they're driving, they're having these, they're doing grocery, like, you will start having information from their activities and extrapolate outcomes from that, than rather going directly and measure the outcome in the traditional way. I think that should start happening rather soon.
Yeah, that's a great point. So try to connect into more relevant outcome measures, right? I mean, this is I think there's a huge opportunity there, because that's sort of seen as an impossible burden to collect that data at this point in time. Yeah, that's a fantastic point. Okay, there's a question in the chat from Alexander Lazar. Avi, it's aimed at you. I don't know if you can see the Q&A. Do you want me to read the question, or do you want to kind of read it?
I'll read it and respond. So Alexander, you're asking, shouldn't the physician, look, there's going to be a prediction technology, and you're still going to have to figure out what to do with those predictions, and help the patient navigate the stresses of the system. And so shouldn't physicians embrace it? And I love that perspective, and I hope it's true. So think about it. The machine provides a prediction. The prediction is just telling you what's likely to happen. It's in percentages effectively, and you still need to figure out what the treatment plan should be for that particular patient, given their needs. And there's still going to be a human who needs to help the patient navigate the stress of the whole thing. Okay, and that will, that should make medical care much better. The question that I'll sort of ask back at you is, how much of your training was focused on judgment and helping the patient navigate the stress of that, versus how much of your training was really about the prediction task? And to the extent that much of our selection of physicians today and the way we train them is driven by their ability to predict, there's going to be a fundamental role in the medical system that's like the one you describe, Alexander, but it might not be, the people who we currently have in that role, physicians, selected through things like the MCAT, might not be the right people for that. And so that's what I'm thinking about when we think about system level change, which is the person who's the patient's core point of contact, who helps them with treatment decisions and navigating the system, might not be the same person 5 years ago as it was 5 years ago, 5 years from now as it was 5 years ago.
Very interesting, Avi. I don't know if Alex is going to jump on the response, but maybe we got Ali's response. I mean, Ali's, implementing AI in the clinic. I mean, are you built for this future of medicine, Ali, or are you from another time?
I hope that I'm from another time, because then that things will change rapidly enough that then you become obsolete pretty quickly. And the truth is, like, this is not a abrupt, it's a process. So people will find other things. Like I remember Avi always gave the example of librarians as like one of the people who became obsolete with Amazon and technologies like that. And I bet you that people who are unemployed and everything are not overwhelmed by librarians. It's like they find other stuff meaningful to do as things evolve gradually over time. So I'm not concerned or threatened. I think we should embrace rather than be fearful of these changes.
David, can you talk a little bit about what we've identified in the global task force, a tremendous shortage in human resources, and what are the opportunities, what we're talking about, to really connect the dots between the shortages of human resources and a million people in Ontario not having family doctor, and us having increased complexity of cancer care, increased burden, and how we can help to deploy those tools rather than promote the fear that we're going to become obsolete.
Yeah, I mean, this is a great point. I think there's two sides to that. I mean, this is where it doesn't have to be disruptive. It can be a co-pilot paradigm, right? Where you actually just get the efficiency advantage, which I think that is very powerful, versus having to turn the whole development of talent upside down. And I think getting comfortable with the technology, like Alex says, I think is a key part of that, and getting skilled at that. Part of that, I think, is understanding where the data came from, how to explain, how to understand, and how to hold that trust. There's a lot of skill development there, I think, that we're going to want to have moving forward. And I mean, also a patient's understanding, I think, in that conversation. And it's exciting. But I think, to your point, Mary, is a huge opportunity to address coverage issues in terms of talent and skills globally. I also think that the AI platforms, like the large language models, are incredibly good at teaching. They've been demonstrated to be consistent in logic, not always accurate. But teachers aren't always accurate either, and often aren't consistent in logic. So there's some great examples of people using it to accelerate learning. And I think that's where the synergies, I think, are going to be absolutely fantastic. A couple more comments in the QA. We have just a few minutes left, I think, Mary. Asking questions around our ability to stage, assign prognostic categories in cancer registries. Where would you start? I mean, with Marion, if you had the data, if you could have the perfect data product flowing through cancer registry, what would it look like based on the comments you heard from Brian? That kind of paradigm, what would be the perfect consumed product flowing through these data supply chains?
It depends very much, because first I need to be sure that I have the coverage of all possible diagnoses or all possible patients in my target area. So I can have perfect data flowing, but if I'm not ensuring that in my registration area that I have defined for which I will inform incidents, I have not all of the possible places and death certificates, etc., that are part of my target area, it's not very significant. It's not very useful, because I can have beautiful stage data for just an amount of a very small amount of my population. So I need to ensure that, and it will depend very much how much interconnection I can build depending on what is in place in the different data sources. So if they have not evolved yet and everything is manually, I will still have a big problem. So that's one of the things. And obviously, as has been discussed here, once I have reached that, there is sort of information that is critical and that could be helped a lot, which is the classification. I mean, we pathologists have been working so much on the standard reporting formats so that at least reports come in a standardized way so that the registry can use them. But maybe the standardized ways can come from this artificial intelligence and all this, just extracting it into a format that is already of much use. But that's something that is very complex, is the classification, definitely. We have more than 7,000 codes, or I don't know exactly how many codes. And as we have been discussing, stage, also stage. So
yeah, we have great technologies to translate languages, but we haven't really used it well to link ontologies and harmonize data, which I think is an area where machine learning AI will be very impactful and help us bridge across. So that huge opportunities. I see Mary has her hand up and she's adjusting her camera. Mary, comment, question?
So, part of the problem is that we spend now the morning here, or the first part of talking about what clinicians need or what different groups of stakeholders need in order to provide better cancer control. So the data supply chain is really not about data. It's about what people need, what information people need to formulate the prediction and then talk about decisions. I think, Abby, you wrote about it, you talked about it, of how difficult it is to implement decisions in healthcare. And we deal with this complexity all the time because people, cancer and healthcare is very complex. Cancer is even more complex than the rest of the healthcare. And we're always asked, what is the one thing that you want to do? What is the one thing you need? And you need 15 things in order to make things work. Can you talk a little bit more about, the decisions chain? When the one decision leads to the need for another decision and another decision, and what happens if it's not taken through the chain?
Who is that for, Mary?
For you.
For me. Okay. Okay, so you described it as a decision chain. So my starting point would be the chain that you have now works for the prediction processes you have now. And a lot of the biggest opportunities are going to be to recognize that might not be the correct chain of decisions once you have machine predictions that work at scale. And so you might need different humans in different places. Some decisions may no longer be relevant. There may be new opportunities for decisions you hadn't thought of, and all sorts of other, sort of spillover effects. So when we think about system level change, what's hard, or one thing that's hard, is sort of reimagining, hey, now that we can do this because we have cheap diagnoses, or we know when somebody's going to be discharged, or we know when they're going to need whatever else, or we know not just broadly what's wrong with them, but we have a very, very narrow diagnosis of exactly what the issue is, then all sorts of other things can come about because of that. And we got to invent those too. So if we are doing earlier diagnosis or different kinds of diagnosis, then our workflow has to change, and we need treatments to deal with those sorts of things. If the machine's doing something that a physician used to do, rather than just swap out the physician, maybe you want to keep the physician in the same place and now empower your pharmacists and your nurses and others to do things they couldn't otherwise do. So I think there's incredible opportunity, but it requires a reimagining of that chain.
Yeah, I think this is a key thing, Avi. I've been thinking about how you call it spot welding, is that if you start to make little changes in an organization, then you get to a point where there's suddenly room and time and resource and skill. It'll start to reorder. So we're trying to understand how we manage the deployment of models in an organization so we can anticipate that reordering. Because if you had a complete diagnosis of a patient on a CT scanner without any further need to do a biopsy, not that I'm suggesting that's the case, would you send the patient home again? Or would you just completely think about the reordering? But that spot welding of AI, machine learning activities, will create an instability. And we may get quite a divergence in practice and process because of that, because it's going to happen differently in a lot of different locations. So steering through the period of change as this spot welding is happening is something that health health systems, I don't think are prepared for. And it's going to produce some tensions, it's going to produce opportunities, it's going to produce frustration, challenge, skills, responsibilities, traditions. Can you predict? That's predictable, isn't it, Avi? I don't need a machine to predict
I need a machine for that.
that. Okay, we're at 10:05, Mary. I think we only had until, or pardon me, 11:05 Eastern,
Thank you.
9:30 in Newfoundland. If you, are we done for the panel? It's been, I think, a great
Yeah,
conversation.
thank you very much. A lot of compliments in the Q&A and comments. I think people agree, people find it interesting, and I think what we need to do is probably connect the dots and connect the opportunities that exist in new technologies, but also, you know, what you talked about, David, is to work on the data, both on data on demand and redefining the burden of cancer and what it means and how to respond to that. And then I think, you know, our work here was to talk a lot about prediction and prognosis and factors that permit that, because as Abby said, that's what we do. That's what we do. That's what physicians do. And we need all the help of the new tools in order to do it better, faster. And we haven't talked very much about how can health system and cancer system benefit of the improved ability to predict and to evaluate new models of care and new ways of really improving the efficiency of and effectiveness of care. I think that thank you very much for your contributions, Avi, Ali, Marian, and David. And maybe I will open it up to the rest of the group for any comments. Brian Roos, Brian O'Sullivan, Jim, for any last comments about the work that we're doing and potential next steps.
I've just been incredibly inspired by that last session. But I feel like I just need to go away and rethink of how I think of things. Yeah.
I have his book first.
Yeah.
I have a hard question for Dr. Berlin. Can you use AI to plan a head and neck cancer case, or you still stick with the little ball down in the pelvis?
So funny enough, the model was trained initially on head and neck patients, and it performs remarkably well. But I think there's a head and neck is more complex radiotherapy than prostate radiotherapy. I hope you're smiling while I say this. So the radiation oncologists have way more nuance and attention to certain details that might or might not be relevant clinically. And breaking that mindset, it might be tougher. So it's a different breed of humans we're dealing there in radiation oncology for head and neck, although the model performs seemingly well in that setting. So it's a matter of evaluation. One of the strategies we're doing is that if you could have a prospective database where patients did bad or poorly after radiotherapy and you know certain toxicities they had, and you could superimpose a plan based on a machine learning method, if that plan would actually render better doses on the areas that you know were traveled down the road, it might be a compelling element to say, okay, let's try this prospectively. But the bottom line is the model performs fairly well, but I think it's a different scenario and different stakeholders, and that needs some different advocacy, if that's the right word.
Mary, I think we're over, but can I comment? I
think that's a good answer. By the way, I think that's a good answer, Ali, because the human factor is in there. There's resistance, and there's all sorts of reasons why it might be more complicated, not just the the situation itself. Sorry, David, I interrupted you there.
No, it's the same direction, Brian, is that there is an open question around how this technology will affect human mastery and skill development. And I think that's an open question in terms of how we keep people pushing the envelope using human intelligence, given the potential to adopt machine intelligence. And that I think this is something that will be, will play out into the future.
All right. I don't see any more new questions in the chat. I think there's a comment to Abby that from Alexander Lazar says, Abby, I think we just need to explain AI better. It's not going to destroy physicians, it's going to destroy physicians who do not incorporate AI in their clinical practice. So I think we all believe this, but I think the opportunity to accelerate the process of change is there. The question is how to go about it and how to harness what new technology offers while still remaining sort of focused on having a very robust information on a great variety of outcomes. I think that's one thing that we've confirmed with our surveys that we presented in the first part of this, is that people who are engaged in cancer control, whether they're health services researchers, whether they're epidemiologists, whether they're patient support organizations, whether they're clinicians, they all need more information, more data in order to improve what they do. And I think that I sort of hoping that we can move forward this concept of data supply chain in order to really link it then to improve performance. Any last comments from the table in Geneva and from the panel?
I have one last comment.
Yeah.
It's we have talked very much about data sharing and the difficulties. So now that we are moving to a different paradigm of machine learning, etc., what about the sharing of those algorithms and helping less developed registries to do things faster? Like, for example, Lynn was texting in the chat that they have seen how specific algorithms have saved enormous time for decoding. So I think there is a space to discuss this and to help, and really to help advance less developed registries by more developed registries. That is important to start thinking about.
That's a great point, Mary. And there was, I think, some fear that these large language models produced by certain companies would grow this talent and this capability, and then would it be accessible, which is not what OpenAI, obviously, OpenAI, the thinking originally was to democratize access to AI. Excitingly, there's a lot of recent work coming out that suggests that very small models can actually be extremely effective. And so I think we'll be able to keep the capability in the hands of many and leverage in a variety of different environments. So hopefully that will lead to access to these kinds of tools to address the problem you suggested, Mary.
Yeah, thank you.
All right. I think we've sort of all exhausted all the avenues of talking. We can talk about prognosis, prediction, AI decision-making for the next several hours, but I'd like to thank everybody who is online, who participated. We said that this webinar is recorded and we will offer it to you to share with your community and share widely. And please send us any suggestions for additional data analysis on the work that we presented in the first part, and any questions that you have. And I certainly greatly appreciate your participation, Abby, because everybody else in the panel is kind of part of the family that we have worked together with. But thank you, David, for getting up early and participating, Abby and Ali. It was a great panel and great deal of new information. So thank you. And thanks again to my colleagues who are here in Geneva working hard on this project. And Thanks to UICC for their support, and to NCI, Sherban and Lynn, who challenged us to do this work. So if there are no other comments, I think I'll close this. And again, very grateful for your help. Thanks.
Thank
Bye-bye.
you to everybody. Goodbye.